Hello, my name's Alan Weil. I'm editor-in-chief of Health Affairs. We are really excited today to hold the first of a three-part series discussing our April 2020 issue of Health Affairs, dedicated entirely to the topic of the integration of social services and health. Now, typically, of course, we do these events in person, and I'd be standing up in front of a room, and this is where I would hold up the cover of the journal and tell you how proud I am that we've published it. Unfortunately, maybe like you, my copy of the journal is trapped in my inbox in an office that I haven't been to in about a month. So I can't hold up the journal, but we're going to test my technology skills and see if I can put the cover up on the screen. So if this is working, you are seeing the cover of the April issue, and I'm really excited to be able to share it with you. I know you will be happy when you can look at it in person. As we often do with our, as we always do with our thematic issues, we also have a tremendous data graphic, which is a two-page folio that captures some of the findings from the journal. And again, I would normally fold it out and let you all see it. Instead, you're going to see it here briefly up on the screen. And I'll put it in full screen so you can have a sense of how much content there is here. This is a really important part of the journal that you really can't feel until, or you can't get a sense of until you hold it in your hands. Well, at Health Affairs, we're really excited about this issue. The timing is never, you can never plan for it. We've been working on this for over a year. These days, everyone in healthcare is talking about social determinants of health. It's a phrase that you hear at every meeting. Behind that phrase is the thorny reality that actually we have lots of entirely separate systems that are designed to meet people's health needs, their social needs. And of course, when we say social determinants or social needs, that's actually many different things. It's housing and food and in-home supports and legal aid and more and more. And so part of what this issue does is it enables us to move behind these fairly broad terms and look more deeply at what they mean and what it really means to integrate services. If we're serious about addressing the social determinants of health, and what we also often hear, that we're going to hold health systems accountable for health outcomes, and we know those outcomes are dramatically affected by social conditions, so we have to figure out how to integrate the social and health supports to meet the needs of individuals and families. It means weaving programs together. It means braiding and blending funding. It means figuring out how to merge and share data sets. And it means supporting each part of these, of the very complex system, to do what it does best, while we also learn from other systems that may operate very differently. So there's a lot to cover here. Now, of course, we prepared this issue before the COVID-19 pandemic, but I think it's fair to say that the relevance of the topics covered in this month's issue has only grown as we have lived through the last month. The terrible disparities that we are seeing, pandemics sweeping through disadvantaged communities, are a stark reminder of the relationship between social well-being and health. And so the imperative to examine and address the social and health needs together has never been greater. We asked some of the authors of papers in this issue to write blog posts after they submitted their papers to talk about how their work relates to the COVID-19 pandemic, and I'd encourage you to look at these posts after the session. So let's move into the content. We've never done this before, so I'm hoping you'll bear with me, and let me just explain how it's going to work. You're going to hear first from David Fukuzawa of the Kresge Foundation. The Kresge Foundation provided financial support for the issue and for this briefing. We're grateful to the foundation for its support. So why don't we first hear from David, and then I'll come back and we'll bring in the rest of you. But let's let David say a few words here.
Greetings. My name is David Fukuzawa, and I'm the Managing Director for the Health Program at the Kresge Foundation. Before I say anything else, let me say I hope you are well and staying safe. Welcome and thank you for attending this virtual event and especially for your interest in Health Affairs April 2020 Special Thematic Edition on Integrating Social Services in Health. The Kresge Foundation is proud to have supported this issue. For those of you who may not be familiar with us, the Kresge Foundation is a private national foundation that works to expand opportunities in America's cities through grant making and social investing in arts and culture, education, environment, health, human services, and community development in Detroit and other cities. Kresge's health program has been a sponsor of other thematic issues of health affairs for over a decade. Over that time, we have consistently been interested in how health policies should address the social determinants of health, and especially address health equity. So our support of this issue clearly grew out of that interest, recognizing that the social service sector plays an enormous role in promoting and maintaining the health and well-being of individuals and communities, and that health policy and research are only beginning to catch up to that fact. Authors Elizabeth Bradley and Lauren Taylor make the powerful case in their book, The American Healthcare Paradox, that better health outcomes are strongly correlated with a higher allocation of resources to the social services sector. At this point, I think it's important to mention that while the health program has sponsored other thematic issues of health affairs, this is the first time we have done so in collaboration with another Kresge program, our colleagues on the Human Services team. The Human Services team shares our interest in advancing more equitable policy solutions for individuals and communities of low wealth. But I think it's also important to point out that for the Human Services team and the field, health is but one of several systems that are critical to help people striving for a more secure and prosperous future. The human services sector itself is in a period of transformation that is seeking to align and integrate multiple complex systems to serve families and communities. The transformation that is happening in the human services sector is not covered in this thematic edition. This highlights the importance of seeing people in the fullness of their lives and circumstances. The current health crisis we are experiencing, not only as a nation, but across the planet, has exposed in a way that we could never have imagined how much our health, safety, and well-being are deeply tied to our incomes, places we live, types of food we have access to, and relationships in our lives. The crisis dramatically underlines a need for greater integration between health and human services. The articles in this issue, we hope, will help to leverage this moment and accelerate this movement towards policies and practices that advance this integration. I wish to thank the editors of Health Affairs and to all who have contributed to this issue, and I want to thank Health Affairs especially for its persistence and commitment to make this online event happen. Thank you.
Well, it's great to have those words from David, and we have really enjoyed the relationship we've had with Kresge. And I'm struck by, as he said, this is the first time they've worked across two of their divisions, and it's just a sign of the importance of that kind of collaboration to address these topics. We're now going to turn to Caroline Fichtenberg, who's the lead author of the overview paper in this issue. We have with us today all four of the authors of the overview, in addition to Caroline, Jorge Delva, Karen Minyard, and Laura Gottlieb. I'm grateful to all of them for their contribution, but particularly want to note Laura and Jorge, who served as theme advisors for this issue, which means they took on a very significant role in assuring that all of the content was of high quality and appropriate to the topics that we're discussing. So my thanks to both of you. When Caroline's done, I will ask a few questions. Actually, I got to ask them before. You'll notice my hair changing and my shirt changing when we move to the next segment. But we'll then return and have a live question and answer segment. For those of you in the audience, this is the important part where you come in. We encourage you to ask your questions. And in order to do so, at the bottom of your Zoom screen, you will see a Q&A icon, and that's where you go to type in your questions. Please use the Q&A only to ask questions so that I can review them. And when the presentations are over, I'll be able to pose them to the panelists. It'll be more seamless than trying to bring hundreds of people in one at a time. We've set aside about half an hour for question and answer. Please type in your questions at any time. Frankly, the earlier the better. It gives me more time to take a look before we get to that segment of the program. As you've seen, we have a few bumps with the technology. Please bear with us. This is our first time using it, but we're really doing our best. And before I turn over to the next segment, just in case you don't see it at the end, I want to remind you that we're going to have 2 additional sessions coming out of this same issue. One that'll focus on promising models for social services and health integration, the other that will look at infrastructure needs for achieving integration, both of them really important topics as well. So we're going to begin with a presentation of the overview paper. Well, I'm very pleased to have 3 of the 4 co-authors of the overview paper in this issue who take a broad look at the topic of integration of social services and health, give us some understanding of what it means, what we've learned about it, why it's hard to do, and what we still need to know. I'm going to turn first to Caroline Fitchenberg, Managing Director of the Social Interventions Research and Evaluation Network. She's a research scientist in the Department of Family and Community Medicine at the University of California, San Francisco. Caroline, let's start with you.
Thank you, Alan. I am going to be sharing now some of the highlights from the overview article that we published with the co-authors that you see on this slide. Myself, Jorge Delva from Boston University, Karen Minyard from Georgia State University, and Laura Gottlieb from UCSF. First, I want to start by highlighting the confluence of factors that are generating the current surge of interest in health and human services integration. The 2 key factors are the accumulation of evidence about the impact of social factors on health that has conclusively demonstrated how important social factors are in shaping health outcomes. This is combined with an interest over the past decade and increasing pressures on the healthcare system to increase value at lower cost. The combination of these 2 trends have generated a surge of interest in integration of healthcare and human services. From the healthcare perspective, which is where I sit, this interest is primarily focused on helping to increase the health of individuals by helping to better address their social risks. And by improving health outcomes, there is a hope that that will reduce avoidable healthcare utilization and thereby reduce avoidable health costs. So what does this health and human services integration look like? In the paper, we describe that it falls along a continuum. With at one end of the continuum, activities like social risk screening and referrals and cross-sectoral care coordination, which correspond to relatively low levels of integration. Further along the continuum are activities such as co-located services, such as medical legal partnerships, on-site food pantries, or community centers that combine health and social services, where health and social services activities are provided in the same place, but still relatively independently. And at the other end of the continuum, you have fully integrated services, where health and human services activities are provided in tandem through jointly funded programs. Supportive housing is an example of this kind of full integration. And again, the goal of all of these efforts is to provide better services for individuals that meet both the health and social needs. Although there is great potential in these integration efforts, they do currently face a few challenges that we highlight on this slide. The first one is sparse evidence, at least to date. There really is very little evidence currently published about which integration activities are most effective in which context. The literature is growing, and this health affairs issue contributes to it substantially, but much more is needed. Second, cultural and operational differences between health and human services sectors create frictions and challenges to integration. The 2 sectors have different goals, languages, ways of working that create challenges. These challenges will ease over time, but in these early days of integration efforts, they are particularly prominent. 3, it is not yet clear how integration efforts will be able to be funded in the long term. Current integration efforts are largely funded by healthcare dollars. This may not be sustainable or ideal in the long run, since healthcare funding leads to integration efforts that are mostly health-focused, as opposed to being focused on a balance of health and human services goals. Finally, and strongly connected to these last two challenges, are the resource and power differentials between the health and human services sectors. These exist and affect all interactions and collaborations between organizations in these two sectors. And again, because many of the current integration efforts are being driven by the healthcare sector and funded with healthcare dollars, that power differential affects integration activities. The infusion of dollars from the healthcare sector to the human services sector could certainly be beneficial, but there are also risks related to that. Some of them are related to healthcare funding potentially leading human services organizations to change their activities to meet the needs of the healthcare sector. It's also possible the healthcare sector may ignore the expertise of existing human services organizations and replicate human services sectors within the healthcare sector, potentially at higher cost. These challenges do create opportunities for research, and we highlight here some of the key research gaps. First is the question of effectiveness. And again, what kinds of integration activities are most effective in what contexts? Second is the question of how to bridge cultural and operational differences between sectors. Here, there's a great need for case studies that help show how organizations learn to work together effectively and how to accelerate the creation of trusting relationships, which are key to effective integration efforts. Third is the question of how to mitigate unintended consequences, particularly for the human services sector. Fourth is the question of financial sustainability. And one of the key points we want to raise here is that it is likely going to be important to reduce expectations for cost savings. Although hopes for cost savings are driving much of the interest in the healthcare sector, it is not the only reason that healthcare organizations are interested in integration. Furthermore, addressing social needs is difficult work that requires substantial resources and where there are few quick fixes. It is therefore likely that better health and human services integration will improve health, but may not necessarily reduce costs overall, and not in all populations. It's therefore important for human services investments to be judged based on whether they generate health improvements and health equity improvements, not just cost savings. And furthermore, there's a strong need for financing mechanisms that combine health and human services dollars so that priorities from both sectors are taken into account. Finally, we want to highlight that there are other things that need to occur to make integration effective. It is very likely that for integration efforts to have maximum impact, they need to be accompanied by efforts to reduce material deprivation and increase financial well-being in society as a whole. Otherwise, these efforts will constantly be pushing against a larger tide of need. One final thought. I want to end here by tying this work to the current epidemic. The coronavirus pandemic is highlighting the connections between health and social risks, and also the importance of integration between health and social services. Health systems around the country are grappling with how to identify individuals who are at greatest need and how to ensure that vulnerable populations, in particular homeless individuals, individuals who are not able to stay home and have to continue being exposed because of their jobs, are protected. Learning how to effectively integrate health and human services is therefore more important now than ever. Thank you so much, and I'll pass it back to you, Alan.
Now we're going to hear from Jorge Delva, Dean of the School of Social Work and Director of the Center for Innovation in Social Work and Health, and the Paul Farmer Professor at Boston University. I should also note that Jorge was one of our two theme advisors. So he comes at this not only from the perspective of social work, but also helping us in a significant way, putting all of the elements of this issue together. Jorge?
Yes, good afternoon, Alan. Thank you for having me here. I'd like to first extend my appreciation to you as the Editor-in-Chief of Health Affairs on leading this initiative along with your team, as well as the Kresge Foundation for the support provided for this very important special issue. And not last but not least, my colleagues that co-authored with whom I work with to co-author the paper. But honestly, as a social worker, as a former practitioner, and now as an educator, and being a person responsible for educating the next workforce of social workers, being part of this conversation and this special issue was very important to me because it's a topic that is very endearing to my life as a social worker, where I've spent my entire career trying to help individuals, families, communities. Some of the most vulnerable communities have access to basic services, healthcare services, economic assistance, social services, psychological help. And so the topic is critical because of what we know, that the number of individuals, families who are left out of care is tremendous. Something that now we are seeing clearly with the COVID-19 pandemic. And so what was exciting about this work was being able to identify work that is going on nationwide, and even some work that's going on internationally regarding the integration of services in one way or another. I appreciated Caroline's description of the work. The summary that she provided is spot on. This is the issue provides a in-depth discussion of different models that are being tried, and tested, and in order to find solutions to the separation of care that exists in society at large, not just in our country but globally. I think we need to move forward with integration of care into both sectors, the human services sectors, the social care area, and the healthcare, continuing to treat people as if we only belong in one area and not the other, just makes us fall short of providing optimal care to people and improving population health. The services that are being more like the initiatives that are being developed from both sides, from the healthcare sectors reaching out to the human services sector through the provision of parenting services, housing support, domestic violence support is incredible, and it's growing. And vice versa, from the human services sectors or the non-government organizational sectors that work closely with communities providing substance use disorders treatment, mental health disorders treatment, for example, parenting classes. As they are beginning to approach the health sector, we're finding the creation of innovative programs. The challenges that Caroline described are there, unfortunately. The extent to which their funding can be sustainable, the funding that it exists to begin with, are all major challenges. Integration of data systems so that they can be more seamless communication. One of the things that our colleague, co-author Laura Gottlieb wanted to share, I asked her, since she couldn't be here, she's actually seeing patients right now as a result of the virus situation. So she sends her regrets not being able to join us today. But one aspect that she said she'd love to see is, she said she and her clinician colleagues would love to be able to provide care and very quickly be able to refer people to social services, to psychological services, and not have to spend hours looking at what organization exists, who's providing parenting assistance, who's helping with legal aspects. And there was a sense of urgency in her tone when we communicated, in part now because she's in the midst of providing care for people being hit by coronavirus. So from a social work perspective, we've in the social work field, we live in this world of identifying the needs and trying to help vulnerable communities, primarily, but all communities have comprehensive care and services for holistic well-being, and the separation of sectors and the lack of integration and communication is just frustrating, as it is for many others, not just social workers. And so this special issue is unique in so many ways in highlighting what exists. It highlights the possibilities, the feasibility of things. Things can be done, they're being tested. So it's no longer what can we do, it is happening. Now we have to refine those, we have to test their effectiveness, as Caroline so nicely described, and work on the nuanced aspects. But this demonstrates the extent to which people who care deeply about providing coordinated services to families and individuals of the need to move beyond the silos that exist. I'll stop and get it back to you, Alan.
Thank you, Jorge. Now we will hear from Karen Minyard, Director of the Georgia Health Policy Center at the Andrew Young School of Policy Studies at Georgia State University in Atlanta. Karen?
Hello, everyone. And I appreciate Caroline inviting me to be a part of this work. And my initial focus as part of the paper was thinking about what are the implications related to financing population health. And over the last 5 years, my colleagues at the Health Policy Center and I have been involved in some work with the Robert Wood Johnson Foundation about innovations in financing population health. And one of the things that emerged from that is that, as Jorge and Caroline have alluded, the social service, personal service sector is challenged. The ability to focus funds on upstream kinds of population efforts is limited. And in this work over the last 5 years, one thing that has emerged is this concept of local wellness funds and the opportunity to see the money in the system in a different way and to position the money in ways that support some of these upstream kinds of services. One of the things that came out in some of that work is the concept of a money whisperer. Somebody in the system who's able to see the money in a new way, and the partnerships and communities that might include bankers and Chamber of Commerce and others with CDFIs, community development funds, are able to see the money in the system in a different way than we have traditionally looked at it from the health or social services sector. And so we called those people who are being able to see the money and to think about it, the money whisperers. And we realized that there are money whisperers at two levels. One is people in general who are able to look across all the money and to think about how it might be able to be positioned. And then there are people who are in the detailed work of the community, and they might see a pot of money. Like, for example, in one community, the local government had put some money aside for human resource, for labor. And someone in the community knew about that, and they said, oh, we're doing a program for community health workers. That's labor. Can we use that money for this instead of it going back into the general fund because it hasn't been used? And it turned out the money could be used in that way. And so the concept of the money in the system and how the money moves and the way that that might be supportive of innovations in alignment and cross-sector work, I think is an important component of this overall picture.
Thank you, Karen. I'm going to ask a few questions and hope each of you will jump in as you prefer. I'm not too likely to direct them at one of you specifically, but I'm going to use the structure of the paper as a bit of a framework here. Caroline, you started by describing a bit of a continuum, everything from screening all the way up to jointly funded and provided services. I think it's fair to say that most health systems start at the first end of that continuum because that seems a little more manageable. And I'm wondering if any of you could reflect on what it takes to move up the continuum so that we're actually really at integration and not just screening and treating or responding to social needs in the health system, which is certainly better than ignoring them, but is not going to capture all of the benefits of integration that are so well documented in this issue. Anyone want to take a stab at responding to that?
I'm happy to take a first stab. I'll say that definitely one of the patterns that we're seeing is healthcare organizations starting out with screening as a way of kind of beginning this work, identifying needs among their patients. And having identified them, that then generates interest and motivation for creating partnerships with external organizations to help address needs that are identified. So, if screening starts to highlight the needs around food insecurity, that may motivate partnerships with food banks. So, for example, we did some research with some community health centers in California. And so that's one of the things that we saw is as food security needs were made much more visible and prominent through the collection of data. The organization then had added motivation and reached out to a local food bank, created a joint food distribution / farmers market in a common area that was very close to the health center that became open to the community as well as to patients. So I think that's one of the kind of mechanisms that we see. I think the other one tends to be more in the primary care realm. I think another one can be around thinking about complex patients. And there, I think there may be more jumping into straight away partnerships with outside organizations, because it's so clear when you're working to improve the health of patients who have both health conditions and social needs, complex social needs, housing instability and homelessness being one big one, that's much bigger than the healthcare sector can handle on its own. And so there'll be, I think, where you see a lot of partnerships as well with housing organizations and other support services. So those are just some thoughts. Would love to hear also Jorge and Karen's thoughts on this.
Thank you, Caroline. One aspect I would add, and it might seem self-serving, but it's really not. The intention is the more organizations, if we go on the healthcare side, can hire social workers to be part of their teams. These ideas will be more central. I'm using an example, the thinking that once we have the people with their skills who are taught to think in these ways, whose entire education is about thinking about person and environment, the ecological model. And this is not to say that other professionals don't. Everyone does to some degree, but social workers are specifically trained to do that. And from conversations with practitioners in primary health centers, in federal qualified health centers, in hospitals, in different states, when I've traveled, where I've lived, every time I hear someone that say having a social worker, community health worker in our team just takes our ability to think in ways we haven't thought of before, light years ahead, and it allows us to. This is their stories. It allows us to connect with the services that are available to our population in ways that without having a social worker in their team, it wouldn't be possible. And that would be the additional aspect that I would add to what you described, Caroline.
I was going to add, I think that's a good point, Jorge. I was going to add that one of the things that we're looking at is what are the elements of these kinds of collaborations that might lead towards success? And we've been talking a little bit about, do they have a shared purpose, a shared vision? Are they able to share data? Like I was mentioning before, is there money to support the work? Not only the work of what they're trying to do, but the work of the collaboration. And then how is it governed? And I think this governance piece gets a little bit to what Caroline was saying about the power differentials, because we see sometimes where the healthcare, public health, and social services go into a partnership together and decide how they want to work together. And we see in other situations where perhaps the healthcare system is in charge and the people in the community are more in an advisory role. So I think when there's a stronger shared governance, that you might get closer to what you were asking about, Alan, as far as getting further in the continuum.
Well, that's a great lead into my next question. For those of us who work primarily on the health side, this seems like almost entirely upside potential. Unmet needs, now we're addressing them, we're finding all these resources. We'll come to the money in a minute, but from a health system perspective, working across these lines seems positive. And there's usually this little footnote that there are some risks associated with this, and I think particularly on the social services side. And I wondered if you all could reflect on why this might not always be positive, and maybe how to assure that it's positive as we build stronger relationships between these sectors. Maybe, Jorge, I could get you to start on this.
I was thinking, as you were asking the questions, I was thinking, relationships are great. Who can be against relationships, right? Nobody's against relationships. But every relationship carries its both ups and downs of it, and they depend, the quality of the relationship depend on many contextual factors, but ultimately on what the individuals bring to the table. So one of the risks that may occur in these relationships is that if the traditional model of operating of calling the shots from the medical side, for example, runs the risk of overshadowing the contributions that the other side, the human services, social care sides can make, and it can always be potentially seen as secondary. And so how does one change that? That's where I was thinking about relationship, because when I've, as I was alluding earlier to my conversations and work with people in different settings, the ones that are working really, really well are the ones when people say, so and so just cares so deeply. They're not self-centered. They're open to new ideas. They're not controlling. Ultimately, what they're thinking about is the outcome for the individual, for the family, for the community, not so much whether they're right or not, whether they're in command and control of things or not. And so it goes towards having a champion in the team to give voices to all the participants. I know it might sound a little social worky, idealistic to think that way, but those are not my words. When people have said we were able to do this because this person was always encouraging multiple perspectives, multiple voices, and was willing to work collaboratively. Now, that's at the individual level. And then, of course, there's the context where I think my colleagues might be able to weigh in a bit more, but I'll leave it with what are the incentives, right? How are people being encouraged to play together, to play well, and to think beyond their own needs, but to think of the individuals and community needs. And I'm sure my Karen and Caroline can talk about those larger incentives that might exist there, whether organizational or financial, that can encourage teams to work differently.
I was thinking, as you were talking a little bit about the issue that there's the importance of the work of the collaboration and what you do together, but every person or organization in the collaboration has their own business to run. And for example, in the hospital or healthcare system, they're about a business, and the margin is pretty slim in the work that's being done. And so it's, even though there may be an interest in and a belief in, or they like the idea, the ability to actually financially do what needs to be done might not be easy. And I was just thinking about right now in the challenges that exist in the healthcare system with the COVID-19 epidemic. It's really interesting in that there's not enough in some places, not enough workers, not enough support. But then in a hospital just down the road here, they're laying off a lot of people because there's no x-rays, there's no elective surgeries, there's no lab work. And so they don't need that. And one person said, you know, it's a very odd environment inside the health system because there are no visitors, there's no volunteers, there's nobody for elective. It's just either us taking care of the people who are really sick or waiting to take care of the people who are really sick with the virus. And I think that points to the questions that we're asking ourselves: how important is collaboration and integration when you run into a crisis? And is it a protective factor if you've already built the collaboration when you get to a situation like this? And like you were saying, the question of where are the mental health workers right now? We need them right now. We can't look for them. We can't build the relationship. We just need them. So it is a very interesting and dynamic environment, and it's even more so right now.
Caroline, go ahead.
The only thing that I was going to add, and this also connects back to your other question, and I don't think of it necessarily as much as a risk, as much as open question, which is, I don't think it's clear yet kind of that the end goal that everybody should be seeking to get to is full integration in all cases for all situations, et cetera. So I think one of the questions here is kind of help figuring out what kind of integration is helpful in which, for what outcomes, for what patients, for what types of organizations, et cetera. And so the risk piece of that is everybody going in the same direction when it's not, that would not be the ideal end state.
So I want to turn to this question of financing. Caroline, one of the critical comments you made was that it's important to reduce the expectation that there will be cost savings. And then, Karen, I was thinking about the fund that you described, and I realized that for many of these integration efforts, the sustainability model at the outset is sharing savings, that the expectation is there will be savings and that will pay for this. So if we need to temper our expectations, but we want to create interventions that are sustainable, how do we rethink what the model is here so that we have the shared purpose that, as has already been mentioned, is so critical to their success?
Well, I would offer that the model should be, how do we make efficient and effective use of combined resources? So this idea, yes, I do think this idea that somehow we're going to be able to pay for this through savings, through healthcare savings, I think is potentially problematic. But instead, we should be thinking about this from the perspective, okay, we have these, we have dollars that we have committed as a society for the purpose of generating health. We have dollars that we have committed for meeting the basic needs of our citizens. How do we best combine those and merge those and use them for services that are connected, integrated, coordinated in ways that generate the best outcomes? So really cost effectiveness should be our metric, and as opposed to the narrower focus specifically on cost savings.
I think you're right.
That would be my thought.
I think you're right that the shared savings are could be one element in a portfolio of how this upstream work is funded, and to think that it's all going to happen through shared savings is not realistic. And in some cases, when you're first starting out and you're trying to deal with these complexities, the actual costs are more for a period of time, sometimes. So I think a broader view of what are all the different opportunities for aligning the resources in the system, including the shared savings, if there are some, is a better approach than expecting that we can totally lean on the shared savings.
Well, these are tough questions we're all going to be grappling with for some time. So I think I'm going to say this has been a terrific introduction to the issue and the themes in the issue. I'm very grateful for the contributions each of you made, and we'll look forward to continuing the conversation as we go along. Thank you to all of you. So I've received a handful of questions. We probably have time for some more, so don't be shy, folks, in typing in the box. But let me just start with one that I thought was particularly interesting. It asks about trust from the perspective of patients. And I'm going to embellish the question a little, expand on that question a little bit, because I think it's particularly interesting. People interact with their health systems. They interact with social services systems. If we're going to integrate, we need the patients to trust both of those systems in and of themselves, and that they're working together. And the question is, do we have any information or knowledge about how patients see these systems, differential levels of trust, expectations, and understanding of how the systems work together? And I'll let anyone who's up for it take a stab at this answer.
I'll jump in, Alan, just with a piece of the answer. It's a complicated question, but I can highlight some work that a colleague of ours, Amelia DeMarcus, led with a group of collaborators across the country, just asking patients how they felt about being asked about social risk at the point of care, so within healthcare delivery settings. And that work's published and available in the, I think they have a couple of pieces, a quantitative piece and a qualitative piece, but they ask people by survey, and then they also ask people in interviews about the experience of being asked about social risk and interventions, related interventions in healthcare settings. And actually what they found was that the strong majority of patients were comfortable being asked about social risk. And what I think was particularly interesting in the qualitative work that they did was that people didn't necessarily expect the healthcare system to resolve the social risk issue, but they wanted to talk about it with their healthcare providers, and it improved their experience of care when they were able to discuss these topics. And again, whether or not the social risk was resolved. And we have some other quantitative work from a randomized control trial where we similarly saw that the talking about social risk is actually separate from resolving social risk. So I think patients really have an intuitive understanding of how social risk affects health and want to be able to have this conversation with their healthcare providers.
Others want to jump in on this question? Okay, then I'll move.
I would just add that I think it's a very interesting question in addition to what Laura said. I think this idea of, one of the reasons I think where there has been a burgeoning in screening for social risks and activities to connect individuals to social services in the healthcare setting is this idea that there is a level of trust between patients and providers that can serve as an entry point for connections to other sector services. But I don't know of any study that has yet compared trust levels, how much patients trust their providers versus how much patients trust social service providers. And I think that's a really, really interesting question. I would hypothesize there's probably some differences between different parts of the social services sector. I think there's a lot of anecdotal report about certainly frustration with maybe governmental agencies providing social services. I know there was a terrible series in story in the New York Times this past year about how a woman was treated in a waiting room, et cetera. So but I'm sure that varies dramatically by setting. So I think that's a really interesting question and would encourage folks to work to answer it.
Let me move to another question. This is one I think many people would share. The person says, the hospitals where I've worked in New York City always had robust social services available. How is what we're talking about here any different? What special services are offered to tackle the problems of poverty and addiction? What does integration really mean? And I think this is a common question. Those who've worked in particularly safety net institutions have seen attention to social issues for a long time. So what's different about this conversation?
Laura, I feel like you would be able to tackle that one.
I'm happy to start a response. I mean, I think everybody has a lot to contribute on this. In some ways, this would be so fun to have the audience, this be a back and forth, but it's just not feasible in this particular venue. I think over the last couple of decades, we've seen a kind of remarkable shift. And if in some New York settings, it feels like there has always been an attention to social services and the availability of social resources. I actually think in the healthcare sector overall, we've actually seen a transition that's actually more marked in the last couple of decades than maybe in the experience in New York. So I can just highlight some examples, but the degree to which technology is facilitating integration, the ability to actually document a comprehensive social history, the advent of more reimbursement opportunities for paying for social services, and that comes through kind of policy level changes, the degree to which we've seen the kind of national professional organizations take up this topic. It's actually, to me, indicative of a sea change. So I appreciate that New York, I think, has been ahead of the curve, but I don't think that has been true across the country. And I just think that the level of interest in this topic has really changed as we've seen the move towards value-based care. I don't think we've actually achieved our transition, but I think that with that transition or that increased interest, we've really seen more healthcare systems really recognizing that they potentially could be doing more around social determinants as a strategy, a long-term strategy for improving outcomes. And it's just given them some more flexibility. So I'll start there and maybe turn it back to the rest of the group.
Karen, since we got the conversation we had earlier got cut off, this might be a good opportunity for you to jump in because you've worked on this on the ground, as it were.
I was thinking maybe I would share a couple of the comments that I shared before. Would that be okay? There were a couple of parts of this article that I wanted to augment, and one was related to how does this work get paid for? Where's the money? And one of the things that we've talked about in this article is that some of the money can come from the healthcare system, and the healthcare system may not experience the full cost savings of what the investment might be. And so where is the money in the system? And I've had an opportunity over the last 5 years to work with some communities on the ground who are trying to think about how to assemble resources in a way that would support population health and support these upstream things. And the communities have converged on this concept of a local wellness fund. And this is something that has grown and has a lot of interest at the national, the governmental, the state, the local level. And so we have an opportunity now to work with 8 different collaboratives in Washington, Texas, California, Ohio, Vermont, Pennsylvania, Idaho, and Oregon who have actually put these local wellness funds to support this upstream investment in place and to learn alongside them. And I think the article is right in saying one of the priority issues for needing to learn more is in this area of financing. The other thing I would add is that the second priority area about the cultural and operational differences between the two sectors, I think that's a really big issue, and it's a little bit what we're alluding to when we talk about trust. It's not just the trust of the individuals, but it's also the trust of the different sectors and how they work together. And in some research that we did in looking at a global review of the literature on co-occurring mental health and substance use and how those things get coordinated, we found some of the same things, that there's a need for a common language, common definitions, cross-sector training, and shared vision. And these things don't just happen for free. It takes a lot of investment, particularly, I'm imagining you, Laura, if you're in the situation, you're trying to take care of patients, and then you think about you don't have exactly what you need. How can all that training or whatever needs to happen immediately? So I think those are 2 areas that I would share.
Thank you, Karen. I want to bring Jorge in part around another question that's come in that has to do with workforce. And we talk a lot about finance and organization, but any thoughts on the workforce needs here, whether it's type of workforce or training of the workforce that would increase the likelihood of bringing these sectors together?
Good question. It's something that schools of social work around the country, along with their partners, schools of medicine, schools of dentistry, of pharmacy, nursing, schools of rehabilitation, public health, have come together to develop these interprofessional educational opportunities for our students. And it's something that's been increasing, and it's related to the earlier question about the person from New York saying, well, what's so new about this? We are already doing some of that. And I think what it is that there is tremendous variation, with some areas working towards integration, towards training the next cadre professionals more closely together, from students at some universities actually taking courses. For example, the group of social workers, nurses, public health would take a class at a medical school, and then the following week, a group of students would take a class in a school of social work, and they would get to not only see what different instructors would teach, but what the context of the learning experience looks like, to get a deep flavor. that's one extreme. Then there's the places where these innovations are not occurring. So there is that whole spectrum of areas of those who are developing innovative programs with those who are developing less. And what everyone says who has participated in these programs, somewhere in the spectrum, that it's changed their ways of thinking about the other profession, and has increased, allowed them to see the world from the outside their professional boundaries, so to say. And so across the country, schools of social work, schools of medicine, and these other health professions are really trying to develop curriculum that helps people learn more about each other so that they can work better. Now, with that said, though, for the most part, from my perspective is that this is still more health centric. So it's still preparing people to collaborate in the context of the health sector, and there's still a lot of growth to be made in how we educate for people across the different professions, so that by the time they're professionals in their NGOs, in the government, state policy programs, in whatever areas they're working, that they can be thinking about how to more closely work with the other sectors and hopefully integrate. But that's the next area of growth that's needed.
The other three of you are in teaching institutions as well, so this is not just a social work question, if any of you want to jump in. If not, let me turn to another question. This is another sort of research question that came up, which is whether there's any evidence on engaging patients in a healthcare setting to talk about social issues has any effect on adherence to treatment or other sorts of patient activation metrics that we often rely upon to show that patients are likely to adhere to recommendations. Do we know anything about this?
I'll jump in there. It's actually the focus of a big study that we have that's right now supported by the NIMHD, but there's not a ton of data about it at this time. What I would say, I'll just go back to that randomized trial that I mentioned earlier, which was in our first trial, we found that providing patients with a sort of one-on-one navigation assistance led to improvements in social risk, but it also led to improvements in this case, pediatric child health. But what was interesting about that study was that those two outcomes weren't connected. So the change in health outcomes weren't mediated. The changes in health outcomes weren't mediated by the changes in social risk. So there was something that was happening that was unrelated to just whether or not the social risk got better. And that could have been that it meant that patients felt more connected to their providers and therefore were more likely to adhere with treatment recommendations, or it could have meant something else. They just felt better cared for, and it doesn't have to do with adherence. But there's some other studies that are showing some promising signs. We just recently done a review of hypertension guidelines, and many of the recommendations in hypertension guidelines over the years have recommended attention to social factors, not in order to resolve the social factor, but rather in order to adjust what we're doing to make it more likely that a patient could adhere to treatment. So decreasing the cost or choosing a less expensive medication is a great and easy example. And there's certainly literature on that topic. So I think, Alan, it's a complicated question, but there are definitely reasons to suspect that attention to social factors, at least taking into account social factors when we're thinking about developing treatment plans, is very promising.
Great, thank you. We have a question about the current environment that we are in, and whether any of you looking out at response to the COVID-19 pandemic are seeing particularly exciting or promising or innovative approaches to integration, particularly given the emerging and now quite well established data about the differential effects of the pandemic.
Also, one thing about as it relates to the resources, some of the work that we've done over the last few years has been in very under-resourced communities. And how do you think about very limited resources and pulling them together to focus on social determinants of health? And I think that kind of experience in under-resourced environments is what we're going to be facing in every environment. And that there are going to be challenges to put together the resources to support what needs to be supported. And in addition, there are going to be different resources that might be available that weren't available before. An example of a community collaborative that was working with the local government to use some of the money that was coming from the new legislation around the COVID-19, actually were growing their work because they were performing a service of providing the social services to people who had been tested positive and needed their food and medications delivered to them. So there might be a lot less resources, and there might be some different resources. And so this takes a particular kind of adaptation to be able to pay attention to the environment and move quickly and assemble things in a way that adjusts to the current situation that we're facing.
Caroline, it looks like you're trying to speak, but we got to get you off mute.
Double muted. I would add to that although it's hard to tell just because in this current process, obviously people are focused on saving lives, not on telling everybody what they're doing. But we are seeing anecdotal evidence already of certainly an increased interest in understanding things like homelessness, what people's housing status is for patients who are coming in, and anecdotal stories certainly of healthcare organizations collaborating, especially those that have a kind of a mission of serving safety net populations, increasing their collaboration with homeless service providers to really mobilize to protect those populations in particular. So I think we're going to learn as we emerge out of this crisis, hopefully sooner rather than later, that there has been, and the groundwork that was already laid for integration, that we were able to build on it and use it somewhat during the pandemic. But it's a little hard to tell at this point.
Okay, I have a long list of questions that have been submitted, and I'm going to take it down to 4, and then we'll wrap this up just to give you a guidepost here. Let me start with one that was, let's see if I can capture it as the author wrote it. It has to do with screening and data sharing and this notion of people enter into the health system feels the need to understand what the social risk factors are. So they ask all these questions, but these are all questions that people have already answered in other settings. Maybe asking the questions builds trust, maybe in some ways it breaks trust because it's repetitive. If we're doing integration, how do we actually integrate not just the service side, but the data side so that people feel like they're interacting with an integrated system as opposed to feeling like they're interacting with very separate systems? Laura, you came off mute. I take it that means you want to say something.
Caroline, you should take, I actually was going to say, this is the perfect question for you because of the work you're doing with the amazing people in San Diego.
Okay. Caroline, take it away.
I mean, I think it's a really, really great question. And unfortunately, I have a little bit of my initial response is, there are two, I think that there's some evidence for both. That on the one hand, asking the questions can help build trust and build up a relationship, which can be very important if we're talking about social workers, community health workers, et cetera. And so we definitely hear of people saying, no, it's really important for me to have those conversations. And also we're hearing things that people say, look, someone filling out a questionnaire is not going to give me the same kind of answers as when I talk to someone and establish a relationship, and then they'll really tell me what's going on in their lives. On the other hand, there is also a need in some contexts for people not to have to fill out the same form 5 times and say the same thing 5 times, especially when you're asking people to disclose things that are hard to talk about, traumatic, often stigmatized, related to economic security or other challenges. So I think it's a both and I think that there are some cases where that is, we definitely want to facilitate the integration as much as possible, and what Laura referred to with San Diego. So San Diego has something called a Community Information Exchange, which was developed by their 211 system. And that is meant to be basically a community-wide centralized record for any individual who touches any service organization in the community, whether it's a healthcare organization, criminal justice system, housing, food, etc. So that when somebody presents to one of those systems, they can be looked up in the system. The person sees what information is already known about them and only has to ask them about things that aren't known. So we're seeing that pop up all over the country, and so we're hopefully on our way to that. It's just that it's going to take some time. And we're also seeing lots of other technologies. There's another paper in the issue, and I know that there's a future, one of these sessions is going to highlight that as well, that are trying to help streamline the referral and communication between healthcare sector and social service organizations and create these networks. Care coordination networks, basically, is what we're talking about. But would love to hear other folks' thoughts, too.
Anyone else want to jump in? I do have 3 more questions. Okay, let me turn to the next one. I had a number of questions come in about community health workers. So we talked about social work, and we have papers on that. But community health workers are another potential bridge between these systems. Wonder if any of you can discuss the role, discuss where we are in potentially increasing that aspect of the health system that could reach across this divide. And I don't know, Karen, if any of the work you all have done, that topic has come up, but that might be a nice opportunity.
I was going to say a little bit about that. Over the years, I've seen some real maturing in the world of community health workers. And one of the groups that I work a lot with is the Pathways Hub work that is focused on both monetizing and codifying the work of community health workers and the funding. And there has been some significant success in some of these initiatives and being able to partner with insurance firms in a way that the particularly Medicaid managed care will pay the community health worker organization pay for performance for them to deliver an outcome related to the individuals that they're serving in a way that results in some of their risk factors changing, thus their health and their utilization of the system. Now, this gets back to Caroline's conversation about, do the cost savings exceed the expenses? And sometimes they might, and sometimes they might not. But I see a real maturing in the ability of community health workers to be this bridge and to make a difference in particularly in people's compliance. I was thinking of one of the first community health workers I met 20 years ago, and she said, "I am she. There's nothing you can do without me. I live in this community. My grandchildren are in this community. If I knock on the door, they're going to answer. If you go to the door, they are not going to answer." And so I don't think they take the place of some of the other kinds of social services that are needed, but I think they can be a bridge between kind of the gritty community reality and the healthcare system.
And if I may add,
yes, all right, please.
Thank you. Building on what Karen, you just said about the maturing professionalization of community health workers, some of you might be aware that within this past year, they created the National Association of Community Health Workers, NACHW. And Google that, you'll get more information. And I think part of that, I think you were describing. And community health workers are one of the fastest growing professional groups around the world, and particularly in developing countries that are partnering with healthcare sectors to reach out to populations, to take the care out into the communities. And they are, thanks to the growth of community health workers, it's helping countries think about how to deliver healthcare differently, as opposed to the model of we have a population, we'll build a hospital, a clinic, and people will come. This is more of how can we take the care out there, and community health workers have been integral in doing that innovative type of work.
Okay, I saved my two toughest questions for last. The first one is, for a health system that is being held accountable for outcomes and sees an opportunity for integration as a way to improve the health of the people they serve, they have to pull limited resources out of what they think of as their daily operations and move them elsewhere. We could call it upstream, we could call it somewhere else in the system. And given the earlier caution that although much of the original motivation for this is associated with the hope for savings, that may not materialize, what does it take to convince a health system, given a limited set of resources, to invest in integration, which really means to move, as I say, dollars that would normally be under its own control to a place that they have less control over? What does it take? Carolyn, I have a funny feeling you're well poised to answer that.
I don't know about well poised, because it's certainly a very complex question. I think that it's about recentering the role of the healthcare sector around health, not disease care, not sick care, but around health. And this is going to be a difficult shift to make, but I think it's about not so much saying, okay, how do we make the most money? What are the different, how do we have, use the parts of the healthcare enterprise that make money to pay for the things that don't? But I think we have to rethink, and I think COVID is a perfect illustration of this. I mean, the healthcare sector is not, it's not an optional, nice to have kind of thing. It's something we all need and depend on. And so I think this is an opportunity for organizations, big and small, to be thinking about, okay, how is it that we invest dollars in such a way to maximize health? And then we need to have the outcomes be tied to health. And that's much easier said than done. But that's big picture wise, I think, what we're talking about.
Karen?
I think that obviously it's going to take a portfolio of investment. We can't depend on the healthcare system to bear the full brunt of this, because health systems have a business that they have to be in. But we have seen some very interesting examples of health systems thinking of themselves as anchor organizations in the community, and of thinking about not just their community benefit dollars, or not just investing in a way that they're going to get their exact money back, but thinking of how they are a member of the community and how they might use other resources that are part of it's like Caroline said, a little bit of a mindset shift to think about what are all the sources of money and how might they be deployed in a way that serves the community and addresses the problem at the same time, and how might they leverage those resources. There's a lot of opportunity for health systems to leverage loan resources that they may have to bring in other capital to invest, for example, in issues around low-income housing. So there are a lot of creative ways to think about this, and it is, like you said, Caroline, a mindset change. And I think sometimes it's hard to imagine these kinds of changes when you're in the chaos of a pandemic.
If I may add to that,
please.
Thank you. And I think to incentivize those changes is where we've seen we need people to expend political capital. It's the leadership that we need. The accountable care organizations is one example of incentivizing, but it came out of national legislation, the ACA, and I think that I'm not advocating for just a top-down approach. I think I believe in the multiple approaches, the grassroots, people caring for their communities, people creating partnership and trust because they care about the health of the populations and trying to find ways to improve the well-being of everyone. And innovations are coming out of that, but it does take, I think, some legislative encouragement, so to speak, to support and encourage people to be more creative and funding to be routed in ways that allows for more spending in communities and thinking more about population health and not just treating the broken limb, which is important, of course.
Okay, so the final question weaves together a thread that has come in from a number of folks, and it's always on my mind, and it goes something like this. Much of the integration that we're striving for is really at the individual or family level. It's services for a person or a group of people. But the real determinants of health are social in the broader sense. They're poverty and racism and underemployment and a lack of affordable housing in a systemic way, not an individual person not being able to meet their rent. If we're serious about solving the problems that are barriers to health, how do we make sure that we don't just stop at integration of person-by-person services, but use that as a point of departure for addressing the longer-term, more systemic barriers to people's health? And if you have the answer, I'd love to hear it. I know it's complex, but I'd love your thoughts on that.
So I'm happy to take a first stab at that. Also, a really complex and thought-provoking question. We end our piece in the health affairs issue by raising this point exactly. I think all of us know that integration alone of health and human services is not enough to generate to enable everybody in this country to have their basic needs met in such a way that would help them live to their full health potential. And I want to highlight also health and well-being, which I do appreciate that question that came in. So it's one piece of what needs to happen. Earlier today I was in a conversation with someone and we were talking about how, we have a Department of Health and Human Services. We have over time but health is a human service. And over time, really, the health and medical enterprise has kind of become this much big money maker. There's a lot of money there, and it kind of has taken this much bigger place in society and in the way we organize our federal departments. But in some way, maybe we should just have a Department of Human Services with health being part of it. And the idea being there that, one of the things that integration hopefully gets us to is a place where we think of all of these pots of money that are being used to create health and well-being in our country. And how do we use them most effectively in collaboration, but also doing their unique roles that they are best placed to do. And so the way I think about this is that hopefully the granular level integration, the fact that we have more and more healthcare providers and healthcare teams across the country aware of what the social needs of their patients are. I cannot tell you the number of times that I've had a healthcare provider tell me, I knew that my patient had issues, but oh my gosh, once we started screening, I had no idea how much food insecurity there really was, how much housing instability, et cetera. So I think it is raising awareness and hopefully building the building blocks to getting us to a place where we can think also more systemically about how we use our resources as a nation to create the most equitable outcomes for all of us. And so it's both not enough. It is clear that there needs to be policy change as well. What safety net settings are doing in many cases is helping to fix people who have challenges because we have an economy, unfortunately, that creates a lot of losers. And so there are changes that we need to make to the way that the ability for people to be able to make a decent living that doesn't exist, unfortunately, for many people. And so that needs to be addressed as well. And anything that we do within the health and human services fields is never going to be enough if we don't also do that. So I think that's just really important for us to keep in mind and in all of the ways that we can to be pushing for all of the changes that are needed.
Thank you, Caroline. Karen?
One of the things that I think about a lot is this concept of national, state, and local, public and private, what I think of as the triple layer chess approach to dealing with this challenge, and that it's not just what we do in the community, it's not just what we decide at the state, it's not what we do nationally, but it's all of these things and how they fit together. And it really is complex. One of the things that we've heard a lot, it started in the environmental area, is this concept of thinking in terms of JEDI, JEDI, the justice, equity, disparity, inclusion, and I think that one of the bright spots, if there could be a bright spot related to the COVID-19 pandemic, is that it shines a very bright light on these challenges of JEDI or disparity or justice that we have been seeing in a lot of different ways. But now it is impossible to ignore all of the issues related to personal distance, the issues to who has to work and who doesn't, the issue of who is more impacted by the disease. And so I have some hope that as we come out of this, we may have firmer ground to stand on to perhaps address some of these challenges.
Thank you, Karen. Thank you, Karen. Jorge, anything you want to add here?
It reminds me, the question, it's an extremely important one. It reminds me of years ago, I'm a part of my career was to be a substance use disorders counselor and then researcher. And I remember a presentation I gave speaking about the correlation between tobacco use and income and socioeconomic status. And after a lot of analysis, I described at least in the United States and maybe in developing country, as opposed to countries that are developing, where the correlation between SES and tobacco use is more complex, is not linear, as it seems to be in the US, where people with higher SES smoke less in general, consume less tobacco products. And I center my talk around that. And afterwards, someone came up to me and said, it was very uptight that I didn't spend enough time talking about the different other types of intervention, motivational, CBT, and so on and so forth. And the person walks away saying, sounds like you're saying that the best intervention is to give people jobs. And I thought, yes, that's exactly what I was saying. I'm not denying that all these other interventions are necessary for people who struggle with tobacco addiction, but that was my point. And I was so happy, despite the person being upset about that, but I was happy that that's the point that came across, because the data shows when you have a job that's stable, you're more likely to have access to foods that are healthier, to live in places that have more conducive to health, to take walks. And we see that now. Who is at home, right? Who's protected versus at risk of being evicted? Who has still, despite being homebound, who has access to care, health insurance, car insurance, food, access to shopping. My privilege is such that I live in neighborhoods that I go shopping and I find the food that I have. I have students telling us they go to neighborhoods where they don't have access to the food. Their lines are for hours. They're standing there. I haven't experienced those. So there's a tremendous difference based on a person's position in social strata. So yes, I do think that addressing the structural problems we have in society, the racism, the social injustices, are all are the bottom line ways, along with all these other integration discussions that we've had, that is needed to improve the well-being of populations.
Well, I thank the three of you for those closing thoughts and the optimistic view. I think the question will be, as the implications of so much unattended to in our society are right in front of us, whether that creates the will to do something about it and to move again beyond treating this as individual person by person responses, which are no doubt necessary, into something that we don't have to have quite this conversation again. So I want to thank Caroline, Karen, Jorge, Laura, all of you for this outstanding paper to kick off the issue, as well as the conversation we had today. To our audience, appreciate your patience as we learn how to do this. As I noted at the outset, we have two other segments based on the content from this issue that get into infrastructure needs and some promising models, which some of the questions today were about those, and we'll take those up next week and the week after. So again, thank you to our authors and speakers. Thank you to our audience for joining us, and thank you to the Kresge Foundation for making it possible to put the issue together and hold this event. And wish you all time to read the journal articles and safe, healthy time as we go through this crisis as a country and as a global community. Thank you all.
Thank you.
Thank you. Take care, everybody.
We're excited to be holding part 2 of a 3-part series discussing our April 2020 issue, which is entirely dedicated to the topic of the integration of social services and health. Our first part was an overview of the topic. Today, we're going to focus on evidence-based practices of integration. Everyone in healthcare these days seems to be talking about the importance of addressing social determinants of health and holding health systems accountable for health outcomes that are often dramatically affected by social conditions. That sounds really good, but it turns out to be much more complex in practice. In the first session, we talked about some of that complexity. Today, we're going to talk about what it looks like when you actually do it. We're going to present information about a number of specific examples of efforts to effectuate this kind of integration, and you'll learn both what some of the promising results have been and what some of the challenges are that arise when you make such an undertaking. Now, of course, we prepared this issue before the COVID-19 pandemic, but I think it's clear to all of us that the relevance of the issue of integration has only grown as we've seen this pandemic unfold. We're seeing tremendous disparities in outcomes and the effects of the pandemic, often tied to unaddressed longstanding social issues. And it's clear, I think, to all of us that we really do need to work together between health and social services to address the pandemic. And hopefully, in doing so, we'll learn even more and bring some best practices to our ongoing efforts to take care of people and families in a more integrated way. Now, in today's session, I want to give you a little bit of a lay of the land of how it's going to work. Just to minimize the risk of any technological difficulties, we actually recorded a session with a number of presentations and questions, and we'll be showing that to you all. So when you see me change my shirt, it's not that I ran out in the hall and put on a different shirt, it's that you're seeing me from a few days ago. My hair will be a little shorter since no one's getting haircuts these days. We're going to begin with an introduction from David Fukazawa of the Kresge Foundation. The Kresge Foundation provided financial support for the issue and the briefing. We're grateful to them for their support. And then after David, you'll hear presentations from authors of a number of papers in the issue. And then when that's over, we'll have time for an interactive question and answer session. So for those of you who are joining us live today, you'll see at the bottom of your Zoom screen the little Q&A icon. At any time, in fact, the earlier the better, I would encourage you to type in questions that you may have. As you're listening to the presentations, you're likely to think of questions. Go ahead and submit them as early as possible so that we can review them. Please reserve the Q&A function solely for questions for our panelists. And when we finish the presentations, we'll have an opportunity then for me to collect some of the questions, and we'll present them to our panelists. I would ask you to bear with us. This is our second time using this technology, and there may be a few bumps along the way, but we're doing our best. And just before we turn to the tape, I want to remind you again, this is the second in a three-part series. If you're interested in an overview, we conducted that a week ago, and then next week we'll be talking about some of the infrastructure needs associated with integrating social services and health, and we'll package those all together and make them available on our website. So without further ado, let's turn to David Fukazawa to give us a few comments from the Kresge Foundation, and then we'll go to the presentations.
Greetings. My name is David Fukazawa, and I'm the Managing Director for the Health Program at the Kresge Foundation. Before I say anything else, let me say I hope you are well and staying safe. Welcome and thank you for attending this virtual event, and especially for your interest in Health Affairs April 2020 Special Thematic Edition on Integrating Social Services and Health. The Kresge Foundation is proud to have supported this issue. For those of you who may not be familiar with us, the Kresge Foundation is a private national foundation that works to expand opportunities in America's cities through grant making and social investing in arts and culture, education, environment, health, human services, and community development in Detroit and other cities. Kresge's health program has been a sponsor of other thematic issues of health affairs for over a decade. Over that time, we have consistently been interested in how health policy should address the social determinants of health, and especially address health equity. So our support of this issue clearly grew out of that interest, recognizing that the social service sector plays an enormous role in promoting and maintaining the health and well-being of individuals and communities, and that health policy and research are only beginning to catch up to that fact. Authors Elizabeth Bradley and Lauren Taylor make the powerful case in their book, The American Healthcare Paradox, that better health outcomes are strongly correlated with a higher allocation of resources to the social services sector. At this point, I think it's important to mention that while the health program has sponsored other thematic issues of health affairs, this is the first time we have done so in collaboration with another Kresge program. our colleagues on the Human Services team. The Human Services team shares our interest in advancing more equitable policy solutions for individuals and communities of low wealth. But I think it's also important to point out that for the Human Services team and the field, health is but one of several systems that are critical to help people striving for a more secure and prosperous future. The human services sector itself is in a period of transformation that is seeking to align and integrate multiple complex systems to serve families and communities. The transformation that is happening in the human services sector is not covered in this thematic edition. This highlights the importance of seeing people in the fullness of their lives and circumstances. The current health crisis we are experiencing, not only as a nation, but across the planet, has exposed in a way that we could never have imagined how much our health, safety, and well-being are deeply tied to our incomes, places we live, types of food we have access to, and relationships in our lives. The crisis dramatically underlines a need for greater integration between health and human services. The articles in this issue, we hope, will help to leverage this moment and accelerate this movement towards policies and practices that advance this integration. I wish to thank the editors of Health Affairs and to all who have contributed to this issue, and I want to thank Health Affairs especially for its persistence and commitment to make this online event happen. Thank you.
This segment, we're going to be talking about evidence-based practices around the integration of social services and health programs. We're going to hear from John McConnell, Director of the Center for Health Systems Effectiveness at the Oregon Health and Science University School of Medicine. We'll hear from Amanda Risser, Senior Medical Director of Substance Use Disorder Services at Central City Concern, also a co-author on the paper about their program. Allison Bovell-Ammon, Director of Policy Strategy at Children's Health Watch, a nonpartisan network of pediatricians headquartered at the Boston Medical Center. Amy Freeman, Research Assistant Professor in the Department of Population Health at NYU's Grossman School of Medicine. And Bonnie Mohan, Co-founder and Executive Director of the Health and Housing Consortium, Inc., a network of more than 70 member organizations in New York City that work on health and housing. We're going to begin by hearing from John, if you'd like to go ahead. This segment, we're going to be talking about evidence-based practices around the integration of social services and health programs. We're going to hear from John McConnell, Director of the Center for Health Systems Effectiveness at the Oregon Health and Science University School of Medicine. We'll hear from Amanda Risser, Senior Medical Director of Substance Use Disorder Services at Central City Concern, also a co-author on the paper about their program. Allison Bovell-Ammon, Director of Policy Strategy at Children's Health Watch, a nonpartisan network of pediatricians headquartered at the Boston Medical Center. Amy Freeman, Research Assistant Professor in the Department of Population Health at NYU's Grossman School of Medicine. And Bonnie Mohan, Co-founder and Executive Director of the Health and Housing Consortium, Inc., a network of more than 70 member organizations in New York City that work on health and housing. We're going to begin by hearing from John, if you'd like to go ahead.
Well, hello, thanks. It's a honor to present to the group and to be on this call. I'm going to be talking about a model known as Project Nurture, which focuses on the integration of addiction care and maternity care, and we're going to be looking at clinical outcomes and outcomes in social services. I want to thank my co-authors and also our funder, the OHSU Circle of Giving. Next slide, please. So by now, it's probably well known to most that opioid use is high and widespread, and there's particular concern among its impacts on women and children. For example, the incidence of neonatal abstinence syndrome in Medicaid babies increased by fivefold between 2004 and 2014. There's also, up until about 2012, we saw a decline in foster care placement, but that has risen since then. Most of that appears to be attributable to increase in drug abuse and opioid use. What might not be quite as well known to the general population is that our healthcare system is really not well designed to take care of these women, and that's true for a couple of reasons. One is that people who are generally focused on taking care of pregnant women, OBGYNs, are often not trained in substance use treatment. Likewise, people who are specialized in giving substance use treatment are often not trained in giving prenatal care or caring for expecting women. Furthermore, there's some things that happen where if a woman is pregnant and identified as having an addiction problem, that often triggers a legal requirement in some states that the providers have to report them, and that the expectation is that the woman's child will be placed in foster care, even if that's not what she would like to have happen, and even if that's not beneficial for all parties. And so that creates incentives for women to potentially avoid both seeking treatment for their addiction problems and for seeking prenatal care. Next slide, please. So Project Nurture is a model that was developed in Oregon. It was a collaborative among a variety of providers who worked with pregnant women and worked with women who had substance use disorders. It was implemented in 3 sites in Portland, Oregon in 2015. And it involved the integration of maternity care, addiction care, social services, legal system, a real strong emphasis on peer support and trust building, being transparent with these women, close coordination with social services. And so there was leadership from the Department of Human Services who sat on steering committees. There were people from child welfare who came to quarterly meetings and coordination, and they helped some of the providers understand how to navigate the child welfare system. They helped them learn how to be advocates for patients if they had encounters with the legal system. So this was really sort of a whole patient center of excellence approach to integrate a lot of disciplines, a lot of different knowledge, and really reach outside of the healthcare system. Next slide, please. There was a lot of enthusiasm for this model, but it had, but also interest in a formal evaluation, and that's where we came in. And so we used Medicaid claims data, and we compared women with opioid use disorder in Multnomah County, which was the county where women who were served by Project Nurture were expected to give birth, and we compared outcomes in those women with opioid use disorders to women with opioid use disorders in other counties in Oregon. So we did a difference in differences approach. So we're looking at trends and outcomes leading up to the implementation of Project Nurture that happened in 2015. We left 2015 out as sort of a washout year, and then looked at outcomes after Project Nurture. We're looking at some clinical outcomes and then also some outcomes in the social service arena. I should mention here that we didn't have data that could directly tie women to Project Nurture, so we would know for sure that they were being treated. So this should be, so really this is kind of an intent to treat assessment. And so we're looking at all of the women with opioid use disorder in Multnomah County, where we know that Project Nurture was taking care of most of the women there. But it's not but we don't have a perfect link there. And so to a certain extent, some of our estimates will be biased to the null is our expectation here. Next slide, please. So what we found here was that the Project Nurture model, the implementation of Project Nurture, was associated with a reduction in placements in foster care within the first 12 months of birth of 8 percentage points, reduction in child maltreatment of 7 percentage points, an increase in prenatal care visits and maternal length of stay. We did not see any changes in some of the clinical measures that we looked at, including preterm birth or placement in ICU. But nonetheless, some generally positive movements that we could pick up, particularly in the area of social services. There was enough enthusiasm before we started this, or before we completed this evaluation in Oregon, to find funding to spread this model to 4 new counties, and some of that is going to be happening in rural areas, which will be a first time for that. So there's some opportunities to learn here. I think general assessment that this is a promising model, but still some challenges around how to find sustainable financing. So taking care of women in Project Nurture does cost more money than taking care of kind of a traditional or average pregnancy. That is being paid for primarily by the healthcare system, but as we see in this study, at least most of the savings are coming out of the social services and foster care. And so there's not a good way to share savings. It's not even clear if shared savings is kind of the best way to roll this out. But I think still concern among the kind of the managed care mindset about whether this is something that they can continue to pay for, whether there's going to be a need for a different type of payment in order to move this forward. So that's one thing that we'll be tracking in the next few years. But to summarize, this is the Project Nurture model. We're finding significant improvements in social service measures of foster care and placement and child maltreatment, some positive increases in prenatal care and maternal length of stay, and expecting to see more change as Oregon rolls this out over the next few years in additional sites. Thank you.
Thank you, John. We'll now turn to Amanda Risser.
Thank you so much for inviting me to speak. I wanted to just add my experience as somebody who was participating in direct care of these patients, who was clinically active at a site where we integrated prenatal care, intrapartum care, postpartum care, well baby care, nursery care, to our Project Nurture cohort at a methadone clinic. I wanted to just talk about a couple of the aspects of this program that were especially interesting. The foundation of substance use disorder care is interdisciplinary care. That's been true since the discipline has kind of been coalescing. And that fit in really nicely with the model because each site had a clinician, and in our case, it was a team of family physicians. There was also a site in Multnomah County that had a team of certified nurse midwives who connected with other professionals in the care of their patients and their patients' infants. There was another team of family physicians, and there were clinicians who treated substance use disorders, so substance use disorder counselors. There were people who provided peer support, either certified recovery mentorship or certified recovery mentorship integrated with doula care, which was a really phenomenal aspect of the program. And we all participated in regular huddling and rounding and case review and care coordination. And we spent a lot of time building relationships with colleagues and community partners. So it was not unusual for me as the clinician, the lead clinician, caring for these patients to spend pretty significant amounts of time on the phone with child welfare workers who were interacting with our clients, with subspecialists who are taking care of our clients, with hospital-based caregivers. And we were able to achieve a huge amount of things that we wouldn't have been able to do in a sort of more traditional, 20-minute visit, half day. And so that was an essential aspect of the program. Another essential aspect of the program is that it really fostered collaboration across sites. There were times where we all came together and shared information, shared what we're up to, shared challenges, and came up with solutions and ideas together. And each site participated in pretty significant innovation and care transformation. For example, at our site, we transitioned from a more traditional Finnegan-based care model for neonatal opioid withdrawal syndrome to a eat, sleep, console model. And we, within a couple years, completely transformed how our hospital was caring for these infants. And that was an effort we accomplished really at the guidance of our patients who were wanting a different way to be supported. And that was really exciting for everybody. Everybody loved that transformation, even the nurses on the floor, the social workers. It was just a really positive thing all around. I think another thing to really make sure that we highlight in this work is that information sharing was also a really critical part of this care. I think one of The foundation of substance use disorder care is, you sit down with a patient, you get a history, you talk to them, and then you spend about 10 minutes signing releases of information. And that was also the cornerstone of our work. We spent a lot of time figuring out how to safely and appropriately share information across our disciplines, which really enhanced the care of our patients. That was really often the key intervention that kept families together, because a lot of our child welfare workers, if they don't have the information they need to make the best decision in the care of infants, they may need to make more conservative decisions than they otherwise would if they had information about the strengths of each family that we held. So I think the things to just call out about the Project Nurture model is interdisciplinary, broadness. Family medicine physicians didn't have to be the ones doing this, but it needed to involve a broad team of folks who cared for the patients across the spectrum of care. And the cool thing about being a family medicine doctor in that setting is that I did their prenatal care, I attended their deliveries, I took care of their infants and them in the hospital, I did their postpartum care, I did their well baby care. And we did all of that. We provided that entire spectrum of care, and it was really meaningful. And then relationships and transformation. So spending a lot of time developing, building, maintaining relationships with all the aspects of care for that patient, especially social service agencies, and then transforming care so that it was more supportive, it was better integrated, and it was more patient-centered. So that was what we did. It was really exciting and continues to be. It's still thriving.
That's great. Thank you, Amanda. Next, we'll be hearing from Allison Bovell-Ammon.
Thank you. Thank you for having me today. And of course, I want to thank my co-authors on the study, as well as our funders of this project. I'll be sharing with you today our findings from the Housing Prescriptions as Healthcare Study, which is a study for families with medical complexity experiencing housing instability and homelessness. Housing instability and homelessness are well documented in the literature to impact health across the lifespan. And there's a number of models, often referred to as permanent supportive housing models, that pair health, social, and housing services together to improve patient health and housing outcomes. However, a lot of those models are focused on single adults with medical complexity and behavioral health conditions, and there's far fewer models for families with children. And so in this study, on the next slide, you'll see we launched a pilot randomized control trial where we recruited families who had medically complex members who were also experiencing housing instability and homelessness to the study. Families were eligible if they met income eligibility criteria for Medicaid, they had a child under age 11 who received primary care at Boston Medical Center, and at least one member met the definition of medical complexity, which we defined as a child or adult having 3 or more emergency department visits in the previous year, or a child with medical conditions that required 2 or more specialists. Families also had to meet a definition of housing instability, which was defined as one of the following: being homeless in the past year, behind on rent in the past year, moving 2 or more times in the previous year, or currently paying more than 50% of their family's income on housing costs. Families, after they were recruited and enrolled, were interviewed at baseline every 6 months for 2 years. And the current study that I'll be sharing with you some findings from today represent baseline and 6-month data. We enrolled 78 families into the study, and 67 of them completed the 6-month follow-up survey. The sample was evenly divided between the intervention and the control group at baseline, and there were no significant differences across all variables in the intervention and control groups at baseline. This slide shows you a diagram of the 2 study arms. Those who were in the control group received the current standard of care, which is a curated set of resources with housing-based focus in the community that patients are able to reach out to, and referrals to hospital-based social workers and care navigation services. The intervention was delivered through a coordinated partnership with community-based organizations who provided intensive housing case management, financial counseling, legal support, and application assistance and priority access to public housing apartments. On the next slide, you'll see some of our findings from 6 months. We also did a differences analysis, and we found that after 6 months, those in the intervention group demonstrated greater improvements in health as measured by lower levels of adverse health outcomes compared to the control group. So for children, this meant that the share of children in fair or poor health was 32% less in the intervention group than in the control. And then we've also looked at parent mental health from the perspective of anxiety and depression. So parent anxiety was measured by the Generalized Anxiety Disorder 2-item questionnaire, or GAD-2, they're on the chart. And parent depression was measured by Patient Health Questionnaire 2, or PHQ, on the chart. Those scales have a 6-point total with a clinical cutoff of 3 for further assessment. And so in the intervention group, we saw an average reduction in scores of 1.38 in GAD and 1.04 for PHQ relative to the control. These outcomes are important because they are both strongly associated with increased healthcare use and costs in the literature generally. However, we have not observed those healthcare use or costs directly in our sample. Further analyses on these outcomes are needed. We're starting to look at the 12-month data, for example, and those are forthcoming. Next slide. We think this study has important implications for health and social policy, especially as healthcare systems transition to value-based care models. And we believe there are 3 major policy implications here. First, the current evaluation of interventions in value-based care models often focus on per-member outcomes. And we see in this study that it's important to assess the child and adult health outcomes for family housing interventions, as well as potentially for other family interventions, in order to capture the full range of benefits. Second, we need to develop more methodologies for capturing these outcomes in order to understand clearly the impact. And then third, it's important to note that in this study, we did not pay for housing costs directly. Rather, we leveraged current public housing investments, and we paired those with other services that were coordinated across the community. And so we know that greater investment in housing resources to meet the needs of families and individuals experiencing housing instability and homelessness on the federal and state level will be necessary in order to maximize service investments from health systems designed to improve population health outcomes. And so in conclusion, the early findings of this study demonstrate that a multifaceted, family-focused intervention that integrates health, housing, social, and legal services improve the overall health of children and the mental health for parents. Thank you.
Thank you, Allison. We will now hear from Amy Freeman. Amy?
Hi, thank you so much for having us come join you today. I also want to thank my co-authors for working on this paper together. It was very much a team effort. So our paper is a little bit different than the other ones on the panel today because it's not so much a a research study with clear results. We wanted to share about our experience developing health and housing consortia in New York City. So since I don't have sort of a clear set of results to present, I thought I would just talk about the model, what its sort of structure and activities are, and then our experience replicating that in Brooklyn and some of the lessons learned that came out of this experience. So just as part of the healthcare reform, the Affordable Care Act, there was and continues to be a particular emphasis on reducing costs by focusing on high-cost Medicaid beneficiaries. And people working in the housing field and on the front lines in healthcare have for a long time been very aware that some of their most medically vulnerable high need and high cost patients are those experiencing homelessness and housing insecurity. And they were also aware that these patients are shared across both the housing and healthcare sectors, and that a lack of coordination and communication between these systems creates gaps in care that are very frustrating for staff and patients alike. So among the partners who came together to form the Health and Housing Consortium, there was a real awareness that the frontline staff in both of these sectors, they share many of the same patients, but they don't always have a grounded understanding of how the other sector functions. And so even the siloed nature of the sectors means they almost never communicated directly or shared information, and they didn't always have, the frontline staff didn't always have the tools or resources they needed. So the idea of the consortium really was to create spaces for these staff to come together as equal partners on neutral ground to do this work together. So the consortium, the Health and Housing Consortium, developed a sort of set of activities to provide frontline staff with tools and resources and a network of relationships to assist them in their work with their homeless and housing insecure patients that have overlapping health and housing needs. So the sort of three main buckets of activities are training and resource development, and this is primarily on topics related to homelessness prevention and housing instability, trainings that would be available to both housing and healthcare staff. A focus on cross-sector communication through interagency case conferences, housing marketplaces, and annual convenings. And I can talk a little bit about those, more about those later. And then a research and advocacy focus on issues like medical respite and conducting an annual hospital homeless count in New York City. So these are the kinds of activities that the Bronx Health and Housing Consortium has maintained since 2011. They've been very successful, a lot of participation and positive feedback over the years with work being done at the city and state level. Some of the challenges of the consortium in the Bronx have been one around sort of larger scale buy-in from some of the hospitals. And then also in terms of funding, the funding model in the Bronx is membership-based with dues, as well as 1 year, generally 1 year, or grant contracts to perform some of this work for particular organizations. And so over the years, the dues alone have not sort of been sufficient to fund the work, and the grant funding is not predictable. So that's been a challenge. And then just also finding that demonstrating the value of a consortium like this, which, is necessary to secure sort of financial stability, has been challenging. And so, primarily trying to show the value of relationship building and communication work. So then just a few thoughts about, we replicated this model in Brooklyn, working closely with the Bronx Health and Housing Consortium, following the same model of the same sort of set of activities, and really focusing on the needs of the frontline staff in the healthcare and housing sectors, starting with trainings and then some interagency case conferences. We have found a lot of interest and support for these activities, very high attendance, very positive evaluations. Our process in Brooklyn was sort of less ground up than in the Bronx. There weren't sort of pre-existing cross-sector relationships that we had to start with. So, one of the lessons learned is that developing these kind of relationships with and between hospitals and housing providers takes time, it takes energy, it takes a lot of time out in the field. The Brooklyn Health and Housing Consortium is funded with hospital community benefit dollars. So that's a different model, potentially more sustainable. We also, there's a different sort of housing landscape in Brooklyn. Potentially, I think, maybe less, fewer sort of housing options for homeless people. So that has sort of set limits on what can be accomplished, and we've needed to think more about policy and advocacy. And also, like the Bronx Consortium and the Brooklyn, it's been challenging to demonstrate effectiveness. And so together, the Brooklyn and Bronx Consortia are working with some of our colleagues in the Department of Population Health, who are evaluation experts, to really start thinking about a methodology for collecting more quantitative and qualitative data to help us sort of show the value. And then just a couple of overarching thoughts about replicating the model elsewhere. We feel that in large cities, having a lot of potential healthcare in-housing partners can be difficult. There are often competitors. We decided a borough-based model could make the scale of that a little bit more manageable. Other large cities might use groups of neighborhoods. And in smaller cities or non-urban places, a single consortium might be sufficient. And then in some settings, rather than creating a separate entity, there might be existing structures that could be used to help start a health and housing consortium, for example, HUD's continuums of care, or other existing sort of coordinating entities that focus on homelessness or housing insecurity. And then the whole premise of the consortium is to provide this neutral ground for these two sectors to come together to work in partnership. So we found it's just really important to secure high-level buy-in from both a healthcare and a housing organization, and get support for in-kind staff time, and ideally some startup and sustained funding if possible. And then in terms of funding, our experience shows that there are different funding models possible, from membership-based and grants to hospital community benefit spending. And in other localities, there might be other options around city, state, or county government funding sources. So that's been our experience with building health and housing consortia in New York City.
Thank you, Amy. Thanks very much. Finally, we'll hear from Bonnie Mohan. Bonnie?
Hi, thanks so much. So Amy just gave a nice kind of overview of how we started at the Health and Housing Consortium, and I just want to go into a little bit of detail on one of our programs that didn't actually make it into the paper, but I think it's a really illustrative example of the type of work that we do. So to kind of step back for a minute and give a little bit of the policy context, at the time in 2011, with the Affordable Care Act, the governor of New York established a Medicaid redesign team that was tasked with addressing the state's bloated Medicaid program and working to improve health outcomes and reduce costs for these high-cost, high-need Medicaid recipients. And the state also applied for a federal 1115 waiver to establish a health home program, which is a care coordination program for high-need, high-cost Medicaid recipients with 2 or more chronic conditions. And so with all of that happening, one of the recommendations of this Medicaid redesign team was to invest in a pilot program of supportive housing for health home members. So for those high-cost, high-need Medicaid recipients who have multiple chronic conditions, providing a rental subsidy for them. At the consortium, we have, as Amy mentioned, an annual convening and of our membership, and to hear about what are the issues on the ground. And at one of these convenings, we heard from these new awarded housing providers who got these contracts to serve this population that they weren't receiving any referrals. And we heard from the health home programs that they didn't even know that this housing program existed and was available to their members. So there was a clear disconnect that was happening here. And so what we were able to do as a health and housing consortium was to establish a work group and to bring different stakeholders together to really help build those relationships and also figure out the best way to make these referrals. It was a pilot program. Initially, there were around 20 units allocated to the Bronx. So it was a really small program, and we knew that we had to make the most of it because it was also a really excellent opportunity to provide housing for people who don't traditionally qualify for the existing supportive housing that's available that usually requires a serious mental illness or substance use disorder or diagnosis of HIV/AIDS. So this was kind of a new opportunity for people who were chronically ill to receive housing support. So we put together this work group. We had the health homes in the Bronx were in the work group, the housing providers, of course. We also brought in managed care to really understand, how do you even define a high utilizer of Medicaid? And together we came up with best practices for how to target high utilizers of Medicaid for these units in order to be able to show savings. We knew that with such a small number of units, if we were not able to show significant savings, then the chances that the program would be expanded would be much more limited. So together, this work group came up with recommendations, established a threshold of around $60,000 in annual Medicaid spending to kind of set as a threshold for a high utilizer. And likewise, while there was a focus on people who had high Medicaid utilization and whose costs could potentially be reduced through a housing intervention, we also wanted to account for folks who may not have a dramatic reduction in cost, but for whom a housing intervention would have a significant impact on their quality of life. So for instance, somebody who is awaiting a transplant and unable to get that transplant because they don't have stable housing, those would be a focus for the program as well. And that person wouldn't show cost reduction. In fact, their costs would go up because they were able to receive the medical care that they needed. But it was a balance of focusing on health outcomes as well as cost reduction. So we put together a toolkit with what we learned, and that toolkit was shared. We shared it with the State Department of Health, and the State Department of Health actually disseminated that statewide to all of their contracted providers as kind of best practices and recommendations. So an example of something that a resource that we developed with input from different sectors and different organizations to create best practices and then to inform policy on a statewide level. And in 2018, so that was back in about 2014 that we convened that work group. And in 2018, the pilot was turned into a permanent program. New providers were awarded contracts, so it expanded, not by much, but it did. The program expanded. And what, again, we were able to do with the consortium is to reconvene that work group, bring in the newly awarded providers who were kind of attempting this program for the very first time and really share learning from those existing housing providers and the newly awarded housing providers. And again, reiterate best practices, revisit our toolkit and recommendations that we had made a few years previously and update it with how the program has gone. Really teaching these providers how to get Medicaid spending data. That's not something that supportive housing providers have ever really been expected to do. And so where do you get that data and how to track it over time? And then again, reviewing the program guidelines and making recommendations to the state. So I think that this just shows on the multiple levels that the consortium can work in supporting those frontline staff with giving them the tools that they need to operate their programs, the providers that are involved in these programs, as well as on a policy level of really informing the state and improving these programs based on the knowledge that we're gaining on the ground. And I'm happy to speak any more to any of our other work.
Thank you, Bonnie. Well, thank you all for these presentations. What I'm going to do is ask a few follow-up questions. I'll sort of go grouping in order by paper and then maybe a few broader cross-cutting questions. But let me go back to John. First, just a quick clarification. The percentage declines were percentage point declines. So actually the percentage decline in the placements and the findings, those were quite substantial as a percentage, weren't they? And you all maybe you can all get off mute so that we can have this a little bit more organically.
Yeah, that's correct. So the slides were maybe a little bit misleading, but just to give you some idea, the rate or the percent of children who are placed into foster care within the first 12 months prior to Project Nurture was about 20%, and then after Project Nurture came down to be about 16%. And then it sort of did the opposite. Or not the opposite, but sort of didn't have a decrease in the comparison state. So the difference in difference estimate was 8 percentage points, but that's sort of, when you've got a rate of around 20 or 30% placements, it's pretty significant or pretty substantial, as you said.
Great. So I want to sort of tend it and bring it back to your presentation about the evidence and what it is that it takes to feel confident about the size of these, the magnitude of these changes. If you could just expand a little bit more on that.
Yeah, I think that I think evidence probably comes at a few different levels. I think that there was enough. So just to sort of the real world of this was. I think that there was sort of preliminary evidence or data to suggest that this model was promising, and it also just sort of seemed like the right thing to do. So as I said at the front of this is a population where the health system isn't set up to treat these women or this population, and so the state was ready to go with that. I think with kind of with an assessment of the available data, with in concert talking to providers and the CCO, the Oregon kind of version of a Medicaid managed care that was overseeing it. They were ready to go. I think there's still interest in really understanding that. And then the evidence really, I think it sort of depends on who's kind of carrying the finances or who's shouldering the risk there. And so we did some back of the envelope estimates around these reductions in foster care placement, and it's it could be something like $200,000 or $300,000 a year, which would be enough to cover the program. That's funding that's coming out of the Department of Human Services, and this program is being paid for by the health system. On the other hand, most of the money sits in the health system, so it's not clear. I think some people were not comfortable with the idea of let's just sort of shift that funding over to the health system side. But we don't see sort of really robust evidence coming, at least out of our study. And there are some limitations to our study of savings on the clinical side. Maybe that's okay, but I think it does sort of lead to this larger question of, the MCOs, should they be paying for this because it's the right thing to do, or under the current system, do they need to see some savings there? Amanda, do you want to jump in and sort of kind of give your sense of what this looks like?
Yeah, we talked about that a lot. Why are we doing this? Are we doing this because it's going to confer cost savings? We weren't sure that was going to happen because we felt like this population of individuals were chronically underserved. And so that we felt that the right thing to do was to invest in their care, and that, hopefully we'd have some benefits that could be translated into savings. And the foster care system was the easiest one to think about. In our first bit of time with this work, we thought, okay, well, maybe we can reduce the preterm delivery rate, maybe we can do this, maybe we can do that. And that felt, it was a small enough group of folks that it was going to be hard to show those savings. We did end up making a pretty significant difference in length of stay for many folks. There ended up being but that was a separate analysis. And again, didn't necessarily translate into Medicaid cost savings. So yeah, I agree with John. We had to be really thoughtful about what's the point. And one thing that we felt like the point was centering around the patient and bringing all of the services to them so that they weren't having to navigate several different systems simultaneously. And I think in an ideal world, we would have been able to do multiple projects centering on this work, including really getting a good sense qualitatively of what that meant for folks and whether, they enjoyed it as much as we did, and felt as satisfied by the work and the care as we did. But I do really, I really felt that decrease in foster care placement, and so did the patients. And I think our work was part of a broader conversation about where should children be, and what can we do to keep children with their families, and what kind of evidence-based treatment programming can we bring to folks to support them in being safe and healthy parents and not disrupt families, because we really conceptualize this work as a way to interrupt legacies, multi-generational legacies of challenge. So that's how it felt on the ground.
Amanda, if I could just follow up with one other question. I was really struck by your comment about collaboration across sites. And I'm just curious, was there an infrastructure built in to make that happen, or did it emerge organically?
Yes. From the very beginning of the work, we met regularly, and we had a steering committee that met monthly, and then we had quarterly collaboratives, and then we had a yearly CME event. And the quarterly collaboratives continue to this day, and we've just kind of all contributed to the pot of funding for the the lunches and kind of organized time off amongst ourselves to take a half day together. Initially the program was funded by our CCO, but then as that funding decreased or went away, we all have pitched in to kind of keep those collaboratives going. And it's pretty cool, because what happens is that we invite folks. So if somebody is thinking about launching a similar program, or somebody starts doing or has been doing similar work, we'll invite them in to participate. I switched jobs, for example, over the summer, and I'm no longer doing the on-the-ground clinical care of these patients. So my colleagues who took over that work still come, and then I still come back, and then I'm in charge of a residential treatment program for women, for example, and some staff from my programming go, and we all participate, and it's just a great way to across our region collaborate, learn new things, share experiences, network, because then if one of my patients needs a service, then I know who to connect them to and how to do that. And that's been a real powerful intervention.
Thank you.
It's also kind of hard work. It's a little isolating, and having support and collaboration can be really sustaining and enhance our sense of resilience and our commitment. And that's been a really wonderful thing. And one of the cool things that we did is we invited child welfare caseworkers and leaders and managers. And I think that was part of the relationship building that was really important, is that we could all be in a room together sharing information.
Great. Allison, you mentioned toward the end that you were leveraging the current housing investment, that you didn't have new resources for that. I wonder if you could just expand on that comment a little bit. What was the availability? You did describe what the non-treatment arm got, but also just thinking about it from a health system perspective, we read that health systems around the country are making direct investments in housing. So just wondered if you could expand on that element of the work.
Sure. So this was built off of a longstanding relationship the Boston Medical Center has with our local housing authority, the Boston Housing Authority. BMC has also made a number similar to a lot of the stories that we've been hearing about across the country, in a large housing initiative that directed funds towards a number of housing-based agencies and partners. What this particular project did was we went to the Boston Housing Authority, who had a deep experience in permanent supportive housing models for adults that were experiencing chronic homelessness, who had medical, mental, and behavioral health issues, and basically built on or had conversations with them about potentially building on that type of infrastructure to think about a family-based intervention. And so what the Boston Housing Authority ended up doing was, one, they let us pay for a full-time staff member within the Boston Housing Authority, so someone who has access to their databases, to the information. She is a BHA employee, but she works exclusively with our patients, which I think was a huge linchpin in this. She was able to walk people through what's a very difficult application process for many people just generally, but especially if you have a lot of medical complexities or experiencing severe instability. But then we also were able to get some priority access under this permanent supportive housing waiver to the units in the Boston Housing Authority portfolio across the city. It is also worth noting that these were scattered site units. We really thought it was important, especially for a family model, that people be able to choose the community and the neighborhood in which they live. And as we know, a lot of factors go into that for families, such as school, childcare, access to jobs, things like that. And so having this partnership and allowing for a little bit of flexibility in terms of where people were placed without having to actually pay the rent was really impactful in this.
That's great. Thank you. Amy, you mentioned the difference between sort of the first consortium coming from the ground up and then replication feeling a little bit more top down. I just thought that was really striking. You said a little bit about it, but I wondered if you could expand on the differences that you experienced in those two.
Sure. Top down might be the wrong term, but what I meant by that was, the idea for the Bronx Health and Housing Consortium grew organically from some folks who were already sort of working together across these sectors on a small scale in the Bronx. And I think in Brooklyn, we were very much aware of these efforts in the Bronx and what they were doing. We intuited that there were similar problems in Brooklyn, that the sectors were just as siloed in Brooklyn, but there was somebody from the hospital side who actually had worked in the Bronx as one of the partners in the Bronx Health and Housing Consortium, who had subsequently come to NYU to work in Brooklyn. And it's just that they didn't already have these partnerships with the street homeless outreach teams or the supportive housing providers. And so it was more, it wasn't like we did a community-based needs assessment around housing needs in Brooklyn and brought together community partners that way. And I think, brought up this idea of what do you think about creating something like they have in the Bronx? And so there was interest on the ground. It's just that the relationships had not already formed, so the need was expressed, the interest was there, but there was more work to do on the actual relationship building side, I think. Not that there also wasn't that work to do in the Bronx, but I think it meant it took us a little bit, and it's still something we're working on.
Bonnie, if I could ask you, and again, if either of you want to bounce off of each other, that's fine. That one line in the paper really stood out for me, which was that the consortia kept their focus on the priorities and challenges of frontline staff. Mm-hmm. And so I wonder if you could reflect on how that happened and how the focus was able to stay there.
Yeah, sure. So that was actually a really important decision that we made early on, that what there was a lot happening around healthcare policy and these new health homes and a new kind of care management model that was happening. And what we didn't want to do was create another program or thing that was going to have to work. What we saw where there was a need is in coordination of what was already existing and what was building and building. As Amy mentioned, there were some existing relationships in the Bronx, mainly with one of our founding organizations was a homeless service provider and had a relationship with a hospital in the Bronx that provided medical care in their family shelters. So there was this relationship that we were able to kind of look to and build off of and realize that other organizations and hospitals don't have this relationship, and they're going to need to as we move into trying to coordinate care around this vulnerable and high-need Medicaid population. So really the intervention became to support the frontline staff that are working with this incredibly complex population, people who have really complex medical issues, are homeless or unstably housed, and they have high caseloads. And so what's the information and the resources that they need right now in order to better serve that client that's right in front of them, or that patient that they're working with right now. And so that was where we, the very first thing that we really did was develop a housing referral manual, because we were hearing that people don't know what housing resources are even out there, or how do you access them, and what's the eligibility criteria. So we thought, like, okay, well, we've got some people in our group that really know housing inside and out, and we can put something together and share that around. And that is something that's really helpful. And then that kind of grew into trainings on different topics. How do you support somebody who's facing eviction or who's in rental arrears? So really just kind of practical topics that wasn't available to folks beforehand. And I think that really helped us grow our footprint in the Bronx and to bring more organizations in. And we made those trainings widely available and really, I think, have found value not just in supporting, providing this service to frontline staff, but also hearing from them what are the issues that they're facing. And that has really helped us with the relationships that we have on with higher level staff and with city and state government to be able to advocate and share the experiences of those frontline staff on the ground to help inform the policy decisions that are happening at a higher level and make larger systemic changes rooted in that on the ground experience.
Great, thank you. So I'm going to ask each of you to succinctly respond to this comment of mine. Health Affairs, of course, primarily reaches a healthcare audience. And as we look at integrating social services and health, there's tremendous interest, awareness of unmet social needs that drive healthcare, poor health outcomes and the like. But frankly, these systems have historically grown up quite separately. So my question to each of you is based on the work you've done. If you had the ear of a health system leader right now, what advice or reflection or comment would you make as they begin to try to understand this topic and maybe make some progress on integrating these two historically very different systems? We don't have to go in order, so if you want to raise your hand or take yourself off mute, that's fine. But I'd love to hear your thoughts on this. Who wants to go first? All right, John, you're moving enough for me to call on you.
So it's a good question. I think that, so let me put in the framework of what would I say to Medicaid administrators or state policymakers, because that's one where I think maybe I've thought the most about it. I think there's sort of two challenges to sort of starting from scratch that I've seen some groups or states or systems or struggle with. One is trying to do everything, and so this sort of social services covers a broad range of things. We're talking about specific population. There's talk about housing here. There's nutrition, so on and so forth. There's a lot of things to tackle. And I think sometimes there's a sort of a notion of, well, if you're going to move outside of the healthcare system, let's do it all. And I think that can backfire. That these relationships take a long time to get right and to nurture. And so I think having some focus is really helpful, just to sort of figure out the details of kind of on a case by case example or a case study type of framework is really helpful. That's one point. I think number two is being really clear about some agreed upon measures. And so social services and Department of Human Services has outcomes that they care about, and the health system has outcomes that they care about. They don't always sync up. And so having some agreement about that is really helpful. And then I think some discussion on the financing is useful. And so, I think the great hope and dream here is that we invest a little bit in some of the social services, and we get some payout in the health system. That might be the case, but there's lots of details to work out there in terms of what are you going to do if you don't find savings. And also, I think to some extent what we saw in Oregon at large was a desire coming from the state for its Medicaid system to invest in these social services and make these connections, but the traditional MCOs being very comfortable and living in sort of a actuarial world where they deal in claims data and they know how those things are priced and evaluated, to thinking about, well, what if we move large buckets of money outside of the system and we get good outcomes, but all of a sudden it looks funny to the actuaries. How do we reconcile that? And so that's sort of what one of the big things that Oregon is really dealing with in its state Medicaid system is just what does it look like if we tell MCO type organizations to go out and do this, and where are they going to get hamstrung? So that's the long answer, but I think sort of focus, measurement, and thinking about the financing are key things that come to mind for me.
Great, thank you. Who wants to follow up from there?
Yeah, I'll jump in.
Bonnie.
So I think one of the things that we've done a lot in educating hospital systems in New York City is, I think that healthcare workers and hospital staff don't necessarily know that the housing and homeless service systems are just as complicated as the healthcare system is. And so a lot of education needs to happen just to make them aware of, when you're sending a patient somewhere to a drop-in center or even supportive housing, really understanding what does that program look like, what's available there. There's a lot of misconceptions that it's, supportive housing is akin to a nursing home and there's, 24/7 nursing staff, and that's just not the case. And so I think a lot of conflict happens there around discharges and in coordination, because there's this misunderstanding about what level of care and services are available in different settings. And also, at least in New York City, but I imagine in every part of the country, housing is expensive and scarce, and there's not a magic ticket to accessing it. So I think that there needs to be an increase in kind of the baseline knowledge of what's out there, but I also understand that an emergency room social worker is not going to have the time or the ability to be an expert in housing, and we can't expect them to be. So kind of a simultaneous, that's where the relationships really come in, and having access to the programs and the people who are experts, but it means being available and having investment and support throughout from higher levels within the hospitals, but that also gets down to the staff, the social workers, the nurses, about what, where can they access, where do they turn when they have a patient who's having a housing crisis, and really getting that support all the way through, and access, and making sure that they are as available to speak to housing and homeless service providers as they would like those providers to be for them. So it takes a lot of work. It's not a magic bullet, but a lot can be done by just establishing those communication lines, establishing points of contact, and making sure that the relationship isn't doesn't depend on that one social worker in the emergency room who actually answers the phone and will talk to you and give you information, but really getting it across through all the staff. And that takes more investment and in time and training from the top.
Great. Thank you, Bonnie.
I can
Allison,
jump in here. Sure, I'll jump in as well. I absolutely agree with everything that John and Bonnie have said. And just building off of that too, I think, not reinventing the wheel, I think is important to remember that there's been a lot of expertise in the social service and housing and legal fields for a long time in developing impactful interventions. And I think to Bonnie's point about education, it's also identifying those places too where once we know about those interventions, how do health systems sort of dock into that? And so I think in a lot of conversations that I've seen around this issue, there's kind of this tension between, do we buy it externally in the community? Do we make health system investments in social and housing agencies or supports, or do we build it internally, and do we hire more social workers and more community health workers internally to deal with these social needs? And I think that the title of this special issue is the word integrating is so important, that there's kind of a need for both the capacity building on the health system side to be able to have social workers and community health workers and navigators who are knowledgeable about external resources, and the investment externally in the community so that they have a bridge to somewhere rather than a bridge to nowhere, frankly.
And
Great. Thank you, Allison.
I would just
Amy, yes.
I was just going to add, and I agree with everything everybody said. And I think from the finance side, at least in New York State, I think hospitals do struggle with this idea of, do we have somebody else do this work for us? Do we build the capacity internally? And I think it is a question of sort of doing both. But in New York State, hospitals do have this requirement to provide funds for community benefit to maintain their tax exempt status. And I would like to see, hospitals are traditionally very competitive. I think it would be amazing if hospitals could think more creatively about combining their community benefit dollars to have a greater impact and focusing it on something like housing. I think a lot could really happen that way. And I think it would be a really, creating flexible housing pools like they've done in Chicago. I think it would be great to have some high level folks at the hospital thinking more creatively about how they can support some of this work.
Thank you, Amy. Amanda, you want to give a message to the health system?
Interesting. I now work in a world where I also interact often with supported housing as well. And I agree with everything that's been said so far. And I actually, one of the things that's happening right now is we're working really hard to try to break down a lot of those barriers. We've been doing that for a while, but now when we have a number of folks accessing a variety of services across the spectrum of our care, really removing those barriers becomes essential in the midst of a pandemic. I think the thing for me that I would tell health systems, I feel like our health system is actually doing a pretty good job generally of being thoughtful about these issues, at least locally here in Oregon. I think the thing that was tough for us is that the way that physicians and care providers are paid is often by visits, in visit increments. And one of the things that became really important to our crew is that we knew that there were some skills and some care coordination that was effectively done by social workers, case managers, care coordinators, but there was actually a fair amount of care coordination that needed to be accomplished by clinicians, such as myself, because sometimes, there would be a struggle to resolve an issue, and it would be, several people working on that issue for several hours, and then, a quick call from me would finish it up. And so we were always having to be thoughtful about which person did which activity, but I wasn't necessarily being paid for, in sort of the traditional model of care provision, to pick up the phone and have a 20-minute conversation with a case manager. So I think that was where it became difficult, and each health system that participated in this project dealt with that a different way. And it was a little more sustainable in health systems that didn't pay their clinicians based on productivity. And where, there was a little kind of a health system level pooling of resources. So I think that's on a little bit more of like a granular clinician level, because it was honestly a little bit hard for me to recruit replacements when I left, because you had to be willing to make some trade-offs if you were working in a setting where you were held to productivity standards that didn't make sense for that kind of interdisciplinary care.
Great. Well, I want to thank you all for your papers and presentations. I think you've really given us a sense of the complexity, but also the potential. There's some really quite outstanding results, whether they're early, middle, or late, and to capture the notion that there are multiple goals here. It's not just about saving the health system money, although that's often one of the goals, but it's about improving care, and it's improving the well-being of families and children. And that doesn't always cost less, but it's a really important thing to do. And we need to harness all of these motivations if we're going to move forward. So once again, thank you for the papers and the thoughts. And it's been a great conversation. We have shown you some of the early conversation, but we got some terrific questions in during the session. And I'm going to focus on just a few. I know we've been going for a while here, but I want to focus on a few that I think cut across the work that all of you have done. And I'm going to begin with a question or a couple. I'm weaving together questions from a couple of people about the role of managed care organizations, CCOs in Oregon. Each of your efforts interact with them in very different ways, so I don't want to generalize, but there are questions about how you engage them, what's their motivation for engagement, how do you engage them, particularly when sometimes different family members or different people affected by policy are covered potentially by different organizations. We've had a conversation about some of the financing elements. So just interested, again, acknowledging that you're each in different settings and states with different approaches, but talk about the role of Medicaid managed care in efforts to integrate social services and health. John.
Yeah, so I think there's, I'd point to two states that are doing interesting things here. The first is Oregon, which you mentioned, and the second is Washington. And Washington has a model called Accountable Communities of Health. And the way that each state is approaching this issue is different. Oregon has a MCO-like entity that's called a coordinated care organization, and they push all the money to that coordinated care organization with the expectation that kind of the money eventually will flow through and find some way to address social determinants of health, connect outside of healthcare. The first 5 years of that, we saw that that was ambitious and didn't go quite as far as the state had hoped. The second waiver that Oregon put in, they put in a variety of extra carrots and sticks to really push the coordinated care organizations to make a greater investment in social determinants of health. That's what we're hoping to observe right now. The Washington's model creates organizations called Accountable Communities of Health, where the funding is separate from the managed care organizations. And so they have a quicker, easier way to make some of the connections that were harder to make in Oregon because they live in that world and they have these cross-sectoral functionalities. And it's kind of a bottom-up. The funding goes there, and then they're supposed to connect to the MCOs. The challenge that they're facing is slightly different, which is that they don't have the big payer arm, the big payer sledgehammer that they can use to move things around. And so they're trying to figure out, how do we become sustainable? Where's our value to the community, and what sort of links do we make? But those are two pretty different and great examples where I think we'll get a good sense of how do you stretch these MCOs? Where are the right boundaries? Where do we need to stop? And how do we how much blending of financing can we do that's feasible and good for patient outcomes?
I think
Allison,
I can
go ahead.
jump in here as well. I think on the, as you raised, Alan, this question around different family members potentially being different members of different NCOs. This has certainly come up in our work as well, and is particularly relevant for families with children, because often children are not the most expensive patients in a system, members in a system. And so thinking about the ways in which the MCOs and the ACOs and the Medicaid waivers are set up, again, to John's point about what kinds of carrots and sticks can be put into those types of waivers that specifically address the needs of families, recognizing that they may be that one individual family or group of people that are living in a different housing development or other things may be different, maybe members of different organizations. And so how do you think about ensuring that they don't get left behind when sometimes the motivation is we want to target these really deep investments and these service investments for the highest cost people. And I think that's been a challenge that I know a lot of states have had to deal with when they're thinking about their 1115 waivers. And I know a lot of states, we obviously look at Oregon and Washington as models for setting up these kinds of value-based care models, but I know other states, Ohio and North Carolina and others, have also been thinking about specifically family-related issues and how you might be able to solve for those within systems.
Amy?
Yeah, I'll just add that it's something we think a lot about here in New York City. It's super challenging in a big city like New York, where you have so many different MCOs covering people in no particular geographic area. So it's challenging. If there were ever, I feel like, a place for a single payer system, I'd love to see it here. I feel like we could get a ton done with a single payer system, but that's kind of beside the point. I feel like, particularly in the Bronx, they've had a lot of success engaging the Bronx Health and Housing Consortium, a lot of success engaging MCOs and getting them at the table. Getting them to fund projects, I think, has been more challenging, but they are certainly willing partners. One way that they've been a partner, so in the Medicaid redesign team supportive housing pilot that Bonnie mentioned, they invited MCO representatives to participate in the work group. And, that helped to sort of bring them into the membership of the Health and Housing Consortium. It was probably the first time some of them had met and worked with community-based organizations at that level. And I think they saw that there could be a benefit there. And there was another project that's, I think it appears in the appendix, the online appendix of our article, where we mention a project called Bronx Views that focused on high cost, high utilizers in partnership with MCOs who provided data for that project to help identify some of their high cost utilizers of hospital systems, and see how those folks could best be paired with available housing. So those were people experiencing homelessness. So I guess my point being that if somebody's looking to start engaging with an MCO, you could first just think about building that partnership, seeing if they could share some data with you for a pilot project, in the hopes that down the line, with potentially value-based payment contracts, you would have your partnership in line and ready to go if a value-based payment contract was possible.
Great, thank you. There was a question about the role of medical legal partnerships. Again, don't know how integrated those are with your projects. I have a guess, Allison, on your end, so maybe I'll start with you.
Yes, definitely. So we had as one of the aspects of our partnership, a medical legal partnership component. And I would say in that work, there were different sort of levels of engagement that the medical legal partnership provided, which I found were really important. Sort of on the sort of higher level, they mostly tried to advise the frontline providers who were doing the direct case management on how to navigate particularly tricky legal issues, for instance, tenant-landlord negotiations, for example, and would help draft a letter that could be sent to the landlord about particular issues, for example. But in a lot of cases, it actually required direct legal assistance, someone having a lawyer go to housing court or other types of court. We had some people that needed to change immigration status or things like that. And so I think that was a really integral part of our intervention. It was a little bit hard to kind of capture in terms of sort of what was being offered, because not everyone had a lawyer going to court with them. A lot of people, the lawyer was really operating in the background and providing invaluable information about what is okay and what is not okay for landlords to do, and what next steps we need to be taking. And so I would say that was kind of a key component of this.
John?
Yeah, so I think that there was that type of connection in the Project Nurture model as well, and I think one of I think it was a little bit more on the informal side, and I'm sorry I don't have my Project Nurture expert here to tell us exactly what was happening, but I think that one of the really powerful experiences that I think everybody involved saw happening was the value of having peer support as part of to accompany people in these legal experiences, and to go to the courts and to stand up and say that they had been coming to treatment, and to walk them through a process that was new. And so it was the legal supports were part of Project Nurture, but I think even having them connected with peer supports and all of that being really integrated, that really made it, made these women who felt like they didn't have a voice, have a voice, and find outcomes that were probably beneficial for them, for their babies, for the system as a whole.
Amy, was there a tie between the consortia and those programs?
So not particularly. I mean, because we partner across hospitals, and different hospitals have their own medical legal partnership set up. I would just say that one of the largest medical legal partnerships is in the country is in New York City, between the public hospital system and the New York Legal Assistance Group, NILAG, and the consortium partners with NILAG on our medical respite efforts, or we partner with them, and that I think that's where it's really been most relevant.
So I'm going to ask one last question that is, again, different in each of your contexts, but it has to do with information sharing. It came through in from a listener. Many efforts at coordination integration trip up over data sharing, whether it's confidentiality rules or data ownership rules or compatibility rules. All of yours have some elements of information sharing, whether it's at the individual patient level or more broadly. Just wonder if, trying to channel our questioner here, you could talk about what the key information sharing challenges were, how they were overcome. Whoever wants to take that first.
I can start. Go ahead. So I'll tell one that's maybe less about kind of electronic information exchange and more about process information. We mentioned this in the paper. One of the first, so Project Nurture had experts from from Department of Human Services come talk to the clinicians and patients and describe what happens in various scenarios. And one big challenge for these women who are pregnant and have addiction disorders is that they're in unstable home environments. And one of the first things that this communication with the Department of Human Services surfaced was the value of having something like a driver's license or legal ID because that would allow them to get into a housing shelter or something like that. In the absence of that, they were stuck. And so just a simple thing like that, sort of explaining the necessary for this type of thing, it's not an electronic health record, or it's not confidentiality in terms of data, but super valuable. And it was that type of, that's a little bit different than what your questioner is asking. But that type of cross-sector exchange was super valuable, and something simple like that, I think, kept a lot of women out of dangerous situations that they might have had in the household.
Yeah, I think the question on data sharing is really spot on in terms of a place where there's a lot of places to get tripped up. Stood up now, worked on a few different integrated housing and health and social services models, and I can say this is definitely a theme that comes up a lot. For our model, just on the sort of back end agreement side, we had MOUs and data sharing agreements. For other models we've worked on, we've done business authorization agreements, BAAs, which has a higher level of legal data sharing sort of capabilities. But on the technology end, I think one of the things that is challenging is not only do housing, health, social services, legal services agencies use different platforms, but I think what we've also sort of experienced as a challenge is that the way in which they enter data and the types of data and the value that they put on different types of data in those platforms varies quite a bit across those sectors. And so what we ended up doing in our in housing prescriptions is we recognized that people were going to have to continue to document in whatever their organization's information system was, that there was just no way that people were going to be able to sort of ditch the rest of their organization and start using something totally new. So we honored that, but we created a centralized system that could be used for sharing information on a family case basis relevant to the intervention. So we didn't necessarily want people to have to double data enter every single note that they were taking on a family. They could copy and paste it over from their other data system if they wanted to, but at the very least that they would put sort of a high level progress note so that everyone in the partnership could see sort of at a 30,000 foot level what was going on with that family, and that someone was maintaining contact, that progress was happening. And then monthly, people would be asked to fill out these reports that, again, was just as kind of a series of check boxes of what services were offered or provided to that family based on the suite of services that that provider was offering. And then we would have twice monthly case review meetings where we could really start to sort of dive in on some of the finer details and have deeper conversations about some of the more complex issues. But that's sort of, we wanted to build it. We obviously needed to recognize we needed to share data across systems, but we didn't want to build something so onerous that people wouldn't be able to use it.
Thank you. Amy?
Yeah, echoing what others have said, I mean, when you work across sectors, everybody has their own system. The hospitals have their EHR systems, often different systems. The community-based organizations function on their systems. And so getting sort of data to talk to one another has been super challenging, if not impossible. I think the consortium has, in our activities, we've really focused in terms of information sharing and bringing people together and doing a lot of face-to-face, both relationship building and information sharing in person. And that works well for a lot of, for our case conferences and housing marketplaces and our convenings and things like that. But I think with, COVID has really made us realize, and we wrote about this a little bit in our blog post, how detrimental it's been to not have a way for these sectors to share data across systems, and it's really detrimental to patient care, for the continuum of care. So it's something we'll really be focusing on. New York State has the the RIO, which is a regional health information organization, and that's been a potential way for some of these organizations to share information, but it hasn't been without sort of its gaps, big gaps. So we'd like to work on that definitely going forward.
Great. Well, thank you all for joining us for 2 rounds, earlier that we recorded and today, to answer some more questions live. I want to thank those in the audience who submitted some really interesting questions. Remind you that, of course, all of these presentations are based on articles published in the April issue of Health Affairs, and if you didn't get your questions answered there, you may find more information. And that this is the second in a 3-part series. The 3rd part will be looking at some of the infrastructure needs, including some around data. So John, Amy, Allison, thank you once again. And this is the end of the webinar. Thank you.
Thank you.
Thank you.
Thank you.
We're really glad you're joining us today for the 3rd part of our 3-part series discussing the April 2020 issue of Health Affairs, which is devoted entirely to the topic of the integration of social services and health. The first in the series was an overview and discussed what it is we know about the benefits and challenges associated with integrating social services and health. The second part of the series presented some promising models and the evidence behind those models. Today, we're going to talk about infrastructure. What does it take to actually achieve integration? And we're using the term infrastructure fairly broadly, as you will see from the presentations today. Now, everyone in healthcare these days seems to be talking about the social determinants of health, and many of them say that health systems should be held accountable for health outcomes that are often dramatically affected by social conditions. So if we're going to actually do this, we need to bring together the supports that individuals and families need, whether it's on the health side or on the social services side. That means weaving together programs, funding sources, data, all the kinds of things that are necessary to work together. That's the topic of today and the series that today's session is a part of. I should say that as we're all adjusting to how to do things virtually rather than in person, we actually recorded a conversation with our authors. And so you're going to hear, after I'm done presenting here, some words from the sponsor of the issue, and then a pre-recorded segment. That's when I run out of the room, change the length of my hair, and change my shirt. That's just me a couple of weeks ago. After we're done with the tape, we'll be able to engage with these authors live. Now, live in this instance means that you can type in questions in the Q&A box at the bottom of your screen. I'll be reviewing those questions as they come in. And once we are able to turn to that segment of the program, I'll be reading the questions, sometimes blending together questions asked by multiple people, trying to figure out how to move the conversation forward. So please, throughout this entire segment, as you come up with questions, type them into the box. I promise you we'll be seeing them and reviewing them, and then we'll engage the panelists at the appropriate time. So, but as we run the tape, you're first going to hear from David Fukazawa of the Kresge Foundation. The Kresge Foundation provided financial support for this issue and the briefing. And then you're going to hear from our 4 panelists, all of whom are authors of papers in the April issue. You'll have their introductions in a moment, but you'll be hearing from Emily Putnam-Hornstein, Yuri Cartier, Dora Hughes, and Shauna Petchel. Those are our speakers today, and those are the folks who will be available to answer your questions. So without further ado, we'll go ahead and roll the tape, and you can hear presentations from these 4 authors about what's in the issue, and you can begin preparing your questions.
My name is David Fukazawa, and I'm the Managing Director for the Health Program at the Kresge Foundation. Before I say anything else, let me say I hope you are well and staying safe. Welcome and thank you for attending this virtual event, and especially for your interest in Health Affairs April 2020 Special Thematic Edition on Integrating Social Services and Health. The Kresge Foundation is proud to have supported this issue. For those of you who may not be familiar with us, the Kresge Foundation is a private national foundation that works to expand opportunities in America's cities through grant making and social investing in arts and culture, education, environment, health, human services, and community development in Detroit and other cities. Kresge's health program has been a sponsor of other thematic issues of health affairs for over a decade. Over that time, we have consistently been interested in how health policy should address the social determinants of health, and especially address health equity. So our support of this issue clearly grew out of that interest, recognizing that the social service sector plays an enormous role in promoting and maintaining the health and well-being of individuals and communities, and that health policy and research are only beginning to catch up to that fact. Authors Elizabeth Bradley and Lauren Taylor make the powerful case in their book, The American Healthcare Paradox, that better health outcomes are strongly correlated with a higher allocation of resources to the social services sector. At this point, I think it's important to mention that while the health program has sponsored other thematic issues of health affairs, this is the first time we have done so in collaboration with another Kresge program, our colleagues on the Human Services team. The Human Services team shares our interest in advancing more equitable policy solutions for individuals and communities of low wealth. But I think it's also important to point out that for the Human Services team and the field, health is but one of several systems that are critical to help people striving for a more secure and prosperous future. The human services sector itself is in a period of transformation that is seeking to align and integrate multiple complex systems to serve families and communities. The transformation that is happening in the human services sector is not covered in this thematic edition. This highlights the importance of seeing people in the fullness of their lives and circumstances. The current health crisis we are experiencing, not only as a nation, but across the planet, has exposed in a way that we could never have imagined how much our health, safety, and well-being are deeply tied to our incomes, places we live, types of food we have access to, and relationships in our lives. The crisis dramatically underlines the need for greater integration between health and human services. The articles in this issue, we hope, will help to leverage this moment and accelerate this movement towards policies and practices that advance this integration. I wish to thank the editors of Health Affairs and to all who have contributed to this issue. And I want to thank Health Affairs especially for its persistence and commitment to make this online event happen. Thank you.
This panel is going to talk about the infrastructure needs associated with integrating health and social services. We're using the term infrastructure fairly broadly to encompass a range of functions, including technological integration, financial integration, alignment of goals and priorities so that systems can work together effectively. We're going to have 4 presentations, and first we're going to hear from Emily Putnam-Hornstein, who's an associate professor of social work at the University of Southern California. I'll turn it over now to Emily.
Thank you, Alan. Really pleased to be here today to just briefly give an overview of our paper, Integrating Data to Advance Research, Operations, and Client-Centered Services in California. This is a paper that was co-authored with Mark Galley, who is the Secretary of California's Health and Human Services Agency, and Michael Wilkening, who is the former Secretary of Health and Human Services in California, and now a special advisor to Governor Newsom. Next slide. So what we discuss in this paper is a really exciting, kind of longstanding transition that's been taking place within California's Health and Human Services Agency, which I suspect is not unique among agencies in having a fairly program-centric design, yet a very strong desire to move towards a much more client-centered delivery of services. One of the things I just want to kind of mention that I think is unique about this project, and which we also detail in this paper, is not only the transition that CHHS has been making, but also the partnership with university researchers, which was really powerful in the data that was created. And so just briefly, as an associate professor at USC, I had the privilege of spending a sabbatical embedded within Health and Human Services to help them think through some of their data initiatives, and some of the work that is discussed in this paper actually emerges from that. So back to CHHS. CHHS, huge. California is huge, home to 39 million people, 12 departments fall under this Health and Human Services umbrella. Lots of really important infrastructure investments being made towards more transactional and interoperable data systems, but as we all know, it can be hard making those transitions from legacy to interoperability. And so the opportunity that we discuss here is the potential to fairly cost effectively and quickly think about opportunities to take historical records that may reside in different cross-program data sets, link those, and use those to inform programs and policies. And so I just want to kind of confirm that what we're talking about in this paper is in no way the creation of any kind of real-time data system for records to be shared. Rather, it's talking about what CHHS has done to assemble all of its data assets across its various programs, link those together so that we can have a much more client-centered understanding of the services that those clients received. Next slide, please. So this project actually began back in 2017, 2018, where through a data sharing agreement that was established with my team at the USC Children's Data Network, we were able to conduct what we have framed as the first record reconciliation in California. And what that meant was we received in a secure fashion information for all clients who received services in calendar year 2016 from each of the CHHS programs that are listed here. So this covered Medicaid records, CalFresh or nationally what are SNAP records, child welfare, developmental services, WIC records. And those records were sent to us where we were able to use an open source algorithm to probabilistically match those clients across those different programs. What was special about the ability to kind of link the data is that often what happens is government agencies will share data with researchers who will then do kind of an ad hoc one-off linkage project, develop some research and hopefully publish it. This record reconciliation was actually designed so that while we were serving as kind of that research partner or third party to link the data, the MOU gave us permission to return all of those linked records to our agency partners within CHHS. So we were linking the data using personally identifiable information, PII, establishing linkage keys between client records, and then returning those linkage keys to CHHS so that they could use those data to inform their design of programs and delivery of services. That first record reconciliation was extended in 2019 with what we call a second record reconciliation. This is the data that we discuss in the paper. And in addition to the records that were initially used, we also were able to incorporate vital birth records, vital death records, and emergency department and patient discharge records. The kind of where we are now is that there has been this incredible asset that has been developed through all these linked records. And we're now working with the state and CHHS is in a pilot planning phase to set up a secure research enclave that would allow for these anonymized linkage keys and corresponding analytic files to be used to support client-centered and data-driven program and policy development. Next slide. And so as my final slide, and I realize for those of you on screen, there is a lot here, but I just want to give a very high-level overview of what this Research Data Hub is being designed to support. So if you start on the very, very left-hand side, because, and again, sometimes I think that we talk about record linkage and it doesn't feel very concrete, so I just want to walk through this. We have right now in California a process by which records can be extracted from the legacy source data systems. So very, very kind of low burden there. There are actually two different agreements that govern the work. If you look to the bottom of the screen, we have a process by which we can conduct record reconciliations. So the personally identifiable data is extracted and linked, and that allows us to create kind of a key that will connect different records for a given client across their program and service interactions. In the upper left hand of the screen, what you see is that we also have a process within CHHS for sharing data across programs within the agency. And so we're working with analysts in each of the programs and each of the departments to create kind of curated analytic files that can be used for research and evaluation purposes. And those data are then going to be pushed into a secure cloud-based computing environment where we would have strict role-based access to the de-identified data. And you can see that there are 3 primary user groups. We're envisioning this being an environment that would support work for analysts within CHHS, external kind of agency and county analysts, as well as university researchers. And we're now at the stage where we have a prototype and are pilot testing this environment. All right, that's it, Alan. Thank you.
Thank you so much, Emily. Next, we will hear from Yuri Cartier, a research associate at the University of California, San Francisco, and part of SIREN, the Social Interventions Research and Evaluation Network. I'll turn it now to Yuri.
Hey, thank you, Alan. So we're going to be presenting, so I'm happy to present today on our paper, which is titled Implementing Community Resource Referral Technology, Facilitators and Barriers Described by Early Adopters. So you're probably aware that the healthcare sector has become more and more interested in screening patients for social risks like food insecurity and housing instability, and then trying to connect patients with resources in the community to help address those risks. Now, healthcare settings have faced a number of obstacles doing the latter, and so we've seen a number of tech startups pop up in the last few years, promising to streamline social risk screening and social referral processes. Next slide, please. So our goal in doing this project, which was funded by the Episcopal Health Foundation, Methodist Healthcare Ministries, and St. David's Foundation, was to understand the functionalities offered by community resource referral technologies and to identify common implementation challenges and lessons learned among early healthcare sector adopters. Next slide, please. So I'll quickly go over the methods with you. We collected data in the spring and summer of 2018, and for the review of the community resource referral platforms on the market, we searched the web and used word of mouth. And to be included, platforms had to have a community resource directory and a referral management system. So we reviewed the features of the included platforms through a demo with the vendors and a questionnaire on the features. We also interviewed people from 35 health sector organizations who had adopted one of the tools we included. And we identified them through word of mouth, vendors, and some good old-fashioned Googling. We interviewed at least 2 organizations per platform and mostly interviewed program leaders and managers, so not frontline staff for the most part. And we analyzed transcripts from those interviews and extracted key themes on their experiences of implementing the platforms. Next slide, please. So what do these platforms offer? The 2 main functionalities, as I mentioned, that we selected for are the resource directory. By that we mean a searchable, regularly updated listing of organizations and agencies that provide services to meet patients' social needs. And referral management, by which we mean the ability to send referrals to community organizations and to be able to track referral outcomes, i.e. to close the loop. And we list other characteristics, if you want to advance to the next slide. And again, yeah, thank you. Below, all of which played All of these features played a role in how the early adopters chose their platform. And an additional consideration was cost, which varied quite a bit between the products and even between customers of a given product. Next slide, please. So coming to our interviews with the early adopters, the most common challenge across informants was recruiting community-based social services organizations to use the platform, which was necessary if healthcare organizations wanted to find out what happened with the referrals. Community partners often lacked the resources to train staff to use the platform, and they didn't necessarily have an incentive to process incoming referrals. One facilitator of external engagement that our informants mentioned was bringing community partners into the very beginning of the process, before the healthcare organizations selected a platform. Within healthcare organizations, on the internal engagement side, informants describe needing to convey the rationale, their vision, and their goals for better integrating social care and medical care to their own end users. They had to develop workflows that actually met the needs and demands of those users, and they had to monitor and manage staff expectations. And a third set of challenges was clustered around the legal and privacy barriers to sharing data with external non-health organizations. And so this included the lack of clarity about what patient information could be shared, with whom, and how. So those were some of the key challenges that we saw. And we know that since we did this study, this field has continued to advance. So there are some of these platforms being implemented by entire systems or states. And we think that there's a lot more to be learned about these opportunities and these implementations. And we're hoping that we'll learn how to better evaluate the implementation of these platforms in terms of their capacity to improve multi-sector care coordination and ultimately improve population health. And with that, I'll thank you, everyone, and pass it back to you, Alan.
Great. Thank you so much, Yuri. Next, we'll hear from Dora Hughes, Associate Research Professor of Health Policy and Management at the Milken Institute School of Public Health at George Washington University. Dora?
Thank you. And thank you for inviting me to participate in this important panel today. The project that I'll be discussing today is entitled Financing the Infrastructure of Accountable Communities for Health, which we believe is the key to their long-term sustainability. My co-author for this paper and for this project was Cindy Mann, who's a lawyer, a partner at Manatt Health at Manatt, Phelps & Phillips here in DC, but also it's a national firm. Next slide. To start very briefly with a bit of background, Accountable Communities for Health are multi-sector collaborative partnerships that span healthcare, public health, and social services. And their aim is to address social determinants of health and health-related social needs, which may include housing, food security, transportation, and employment, among others. There are over 125 accountable communities for health, also known as ACHs, across this nation. Some of the more prominent examples are the Center for Medicare and Medicaid Innovations Accountable Health Communities and Integrated Care for Kids model. But there are other models sponsored by private foundations, such as the California Accountable Communities for Health Initiative, also known as CACHI, and others are supported by states. Rhode Island's Health Equity Zones is an example that I might mention. Next slide, please. All of these accountable communities for health are quite variable. Some are public health focused, others are more aligned with healthcare systems or social service organizations. At their core, they have a number of essential elements in common. First, all ACHs have a backbone organization that assumes accountability for the community health. This backbone organization engages community residents, it helps to build partnerships. There is a formal governance and leadership in ACHs. Many of them boast fairly robust data analytic capacity and are able to share data across health and social service sectors. The ACHs acquire funding and they support a targeted portfolio of interventions in response to identified community health needs and priorities. When we think about policymakers, there's a lot of focus on providing funding for the actual services and interventions offered by the ACH. But we believe an equally compelling question is, how do you support the ACH itself? Many of these essential elements we would consider our infrastructure needs of the ACH and must be supported in order to improve the ACH performance and effectiveness, as well as to ensure long-term sustainability. And so this is the question that Cindy Mann and I set out to explore. What are some of the resources available to support the infrastructure functions of the ACH, and not just the programs and services offered through the targeted portfolio of interventions? Next slide, please. Across three main categories, we found multiple and quite credible options for financing the infrastructure functions of the ACH. If we start with the first category, public health and social services funding, certainly and especially within the Department of Health and Human Services, a number of the grant programs and cooperative agreements would support infrastructure functions of an ACH. These functions include community engagement, establishing partnership, outreach, the data collection and analysis, program evaluation. The whole gamut of infrastructure functions could be supported by a number of different programs. But certainly we found, if you look at other departments, they too offer programs that could help to support the infrastructure function of the ACH. As one example, if you look at the Department of Agriculture, their Supplemental Nutrition Assistance Program, also known as SNAP, supports outreach, and many ACHs are in fact providing outreach to community residents who are facing food insecurity. There are additional programs at the Department of Labor, certainly the Department of Housing and Urban Development too, that would be useful. In our second category, public insurance programs, we found a number of strong candidates there as well. If we look at Medicaid as one example, there are a number of pathways that ACHs could pursue to obtain infrastructure funding. If we look at Medicaid Managed Care Organization contracting, MCO contracting as one example, as one very simple way, states could require MCOs to make contributions to support ACH infrastructure functions, thereby spreading the cost of the ACH across all of those that would benefit. Similarly, Medicaid MCOs could actually contract with ACHs to provide services such as care coordination or administrative support. In a more creative way, we think that given a number of states are supporting value-based arrangements that are incentivizing MCOs to provide non-medical services to address social determinants of health, we think ACHs could be terrific partners. And if ACHs were able to share some of the savings generated through these arrangements, that would be another source of revenue to offset some of their infrastructure functions. And in the final category, looking at private and philanthropic initiatives, certainly I already mentioned that foundations are an incredibly helpful source of support for infrastructure activities for ACHs. However, we did identify some newer mechanisms, or at least less frequently used mechanisms, that are also very important for ACHs. As one example, the Department of Treasury supports community development financial institutions, CDFIs, and we have identified instances in which they are partnering with ACHs to support local economic revitalization initiatives. As one example, this CDFI, the Local Initiative Support Corporation, or LISC, is participating in the ACH in Washington State. Next slide. We think that for ACHs who are looking to acquire funding beyond funding for programs and services, but actually to support their infrastructure functions, there are 4 questions that they should ask themselves. The first, who is involved in the ACH and what are the core activities? Who is involved, and the core activities will very much dictate the funding streams that are available for the ACH. And in particular, we think that states are particularly valuable partners because they allow access to potentially bigger pots of funding, whether through Medicaid or some of the state block grant programs through some of the departments that we outline in the paper. The second question is, could infrastructure functions be reimbursed as direct or administrative costs? That is a very important question. Administrative overhead funding is incredibly important, very flexible source of funding for ACHs who need infrastructure support. However, ACHs, some of the infrastructure services, such as training or case management, could also be reimbursed directly through some funding streams. And in those cases, the ACH could be reimbursed directly, but they could also charge administrative costs related to providing the service as a second source of funding for their infrastructure functions. The third, a question often asked is the ACH seeking to braid or blend funds? We found that many of the grants and funding streams could be braided, meaning that these funding streams could be coordinated, but the funding streams at the end of the day, they have to be used for their purposes. They have specific reporting requirements and permitted uses by their funding authorities. On the other hand, we found very few instances where publicly sourced funds could be blended, i.e. pooled or combined. And we think that for ACH seeking to use blended funds, they really should look towards foundation supports or private sector or state and local funds that may have more flexibility in that regard. And the final question, what is the time frame for needing the infrastructure support? And this is a fairly important question as well. Certainly for startup costs, ACHs may look to foundations or other time-limited sources of funding. For those that are looking longer term for longer term sustainability, they may want to look at other revenue streams such as Medicaid MCO contracting or state plans that may require, that have a longer time horizon and could be more suited for longer term support for ACHs. And so in conclusion, we certainly from our analysis, we found that there are again multiple incredible options to fund the ACH infrastructure. We think that such funding is absolutely imperative for the long-term sustainability. But that being said, we do think that policymakers could better define and clarify infrastructure functions. They could explicitly allow such functions to be permitted uses of funding across the programs and categories that we outlined in this paper. We also think that policymakers could test and perhaps expand some of these newer mechanisms such as CDFIs or social impact bonds or wellness funds that too may be an important source of revenue for ACH infrastructure functions. I do want to acknowledge that we had a number of colleagues who helped us with the analysis and with this paper, Elizabeth Durbin, also at Manat, and my colleagues at GW, Jeff Levy, Jan Heinrich, and Helen Mittman. Thank you, Alan.
Our final presentation will be from Shauna Petchel, a PhD candidate at the School of Public Health at Oregon Health and Science University and Portland State University. Turn it over now to Shauna.
Thank you, Alan. I'm really pleased to be here today and be presenting for you an overview of this paper, which is exploring how health and social service leaders perceive the organizational risks of cross-sector partnerships. I want to acknowledge the Oregon Rural Practice-Based Research Network, which is an organization that is leading the CMS Accountable Health Communities project in the state of Oregon. They were really instrumental in completing this project. I'd also like to acknowledge my two co-authors, Dr. Cheryl Gelman and Dr. Bruce Goldberg, who are both faculty at the School of Public Health at OHSU and Portland State here in Oregon. Next slide, please. So we've seen in recent years that there is an increasing interest in this idea of strategic alignment of services across the health and social sectors within communities for health models. And we know from the literature as well that many organizations have embraced this sort of aspirational language of cross-sector collaboration in thinking about how to address social needs. But at the same time, the evidence is somewhat mixed for whether health and social services organizations are succeeding in finding ways to actually coordinate their delivery of services beyond generating referrals across sector lines. So the purpose of this project was really to explore how organizational leaders in both sectors perceive risks in cross-sector collaboration and whether those risk perceptions can help us to try to understand why it is that we might see people embrace the idea of collaboration and at the same time still struggle or face disincentives or barriers to making operational changes within their organizations. So this project was a case study of 4 regions in Oregon that were participating in the CMS Accountable Health Communities Project, which is an initiative to align health and social services delivery for Medicare and Medicaid beneficiaries through screening and care coordination networks. I conducted interviews with leaders from 9 health services organizations that were just starting to conduct social needs screenings in the summer of 2019. I also recruited leaders from 13 social services organizations in those same 4 regions who were positioned to begin receiving referrals as a result of the AHC screening. So we found that both health and social services leaders perceived risks to their organizations when they participated in cross-sector initiatives or when they contemplated participating in a cross-sector initiative, and that this helps to explain why sometimes people might hesitate to commit their organization to investing staff time or investing resources in projects like Accountable Health Communities, even if they support the overarching goals of the project or perceived value in the project. So, for example, we heard leaders from both sectors worry that the social services capacity within their communities was already stretched very thin, and they doubted whether social services organizations would be able to respond to new referrals if they made them. We also heard concerns from people that entering into these kinds of collaborations could potentially expose smaller organizations to risks of exploitation from more powerful partners in the collaborative. And this dynamic was especially true for smaller social services agencies that worried that they lacked mechanisms to ensure accountability if they entered into partnerships with health systems or hospitals. We heard that differences in how populations and benefits are defined across health and social services policy can create concerns at the point of care that organizations will be out of compliance with their funding requirements if they try to coordinate service delivery. And we also heard a concern that developing these models to coordinate services really requires intensive time on the front end in relationship building and spending time in meetings with community partners. But particularly for social services organizations, there is no clear reimbursement mechanism for that time that must be invested right now. So we found that despite all of those perceived risks, both health and social services leaders that we spoke with did perceive a lot of value in these efforts. They tended to describe the value of projects like Accountable Health Communities as being at the community level and having data to drive better decisions about regional investments or being able to better match available funds with community needs. It was a lot less common that we heard people describing that the value of this project or the reason why they were engaging in this project was because they saw it as a way to improve care delivery for individual clients. We also saw that health services organizations perceived social needs screening projects like AHC as a tool that could really help them to better transition away from a fee-for-service model by helping them to generate population-level data that they could use for planning and reporting purposes. However, we also saw that the reverse was actually true for social services leaders. So they described trying to move toward a fee-for-service payment model as a more sustainable funding and business model than trying to rely on donations and philanthropic grants. And they perceived these social needs screening projects as one way that they could enter into conversations and then eventually try to enter into fee-for-service arrangements with healthcare partners. So in summary, we know from this work that, that health and social services leaders both perceive risks and rewards in these cross-sector collaborations. And we think that this study really reveals opportunities to better design future social needs interventions so that they can account for these perceived risks and perceived rewards for both sectors when they are being asked to engage in this work. Thank you so much. And with that, I will turn it back to Alan.
Great. Thank you, Shona. I'm now going to ask some questions. I have a couple for each of you, but if you hear a question or an answer that speaks to you and you want to jump in, please do so. So let me go back, Emily, to you and your work. I am curious, you have this incredible collection of data from different programs. Are there places that people, as you were doing the work, thought it would be great to have the data as part of this database, but they were unavailable either for technical reasons or confidentiality reasons or governance reasons?
Yeah, that's a great question, Alan. So I think there are definitely a number of other data sources that are not a part of this linkage activity right now, including education or school records, employment records. The reason for that is that those data actually fall under the governance of other agencies. And so the plan was to first really try to kind of get, in some ways, all of the data that fell under Health and Human Services in order and integrated. But I'm really excited to report that there are a number of conversations taking place in California about how this effort that's being led by CHHS might grow and expand and eventually be able to incorporate data from other agencies.
Well, my second question may have a similar answer, but you've created a tremendous analytic tool, but obviously the potential would be an order of magnitude larger if you could do this in real time or near real time and use it for real-time case management and engagement with clients and families. Is that even an imaginable goal? Is it something you all have talked about? Do you have a sense of what it would take to get there? Or is that just, as I say, sort of an order of magnitude more complex and therefore completely on the back burner?
Definitely an order of magnitude more complex. I think it has definitely been talked about, but the nature of not only the technology, but also the legal agreements that would be required to kind of shift from using data largely for kind of policy and operational purposes to actual kind of client services would also be different. I think that the way that we're thinking about this, though, is that, truly, we were able to get more than 40 million records linked in a matter of weeks and sent back to the state. So in some ways, what we're hoping is that being able to work with this data and understanding the value of being able to understand individuals as individuals who touch and interact with multiple services will really propel investments and efforts to move towards those case management models that are able to draw upon integrated data. And we do think that there's real value to starting here because it doesn't take years, it doesn't take hundreds of millions of dollars. And I honestly think that a lot of the agreements and the structure that's been established in California can potentially serve as a great model for how other states can stand up similar projects with relative ease.
Thank you so much. Yuri, in the work with these technology platforms, I was struck as you commented that the primary barrier that you identified has to do with the use by the social services partners of those platforms. I'm curious, are these technology companies that are developing these systems, are they doing any engagement with the providers, the service providers, or are they sort of scouring data sources for potential partners. I guess the question is, if I'm a health system and I'm getting one of these platforms, am I getting any of their intelligence and insight about the capabilities of these potential partners, or is it really just sort of a data link?
So I would say that it really depends, because a few of the vendors we spoke with placed a lot of emphasis on not only setting up the technical aspects of the platforms, but they have, as part of their setup phase, facilitated community gatherings to basically introduce the platform to end users in both healthcare and social services, but especially the social services, and figure out what those users needed. On the other hand, and so that was what we found, although this is beginning to be less and less true, was at the time that we started doing demos with the platforms, some of them fell into being really exhaustive and comprehensive. And so they were scraping all of the 211 databases and trying to give a national directory of all the resources that could possibly exist, where others focused on very limited active networks of partners. So one by one, the directory would grow as partners join the network. And so we found that the engagement processes by the vendors sort of fell along those lines. Now, as it's come out that that this external engagement is key to these networks actually thriving, we've seen the vendors take on a greater role, but that then it's a little bit of a point of tension, because if it's the vendors, then at some point that means that the healthcare organization that is often the main customer has already advanced sufficiently in the negotiations with a particular vendor to be having them come and socialize the platform to others.
That's very helpful. I was also struck in the paper, you say that the elements of screening were relatively consistent across the different vendors. And I just wondered if in the conversations you had, people felt that they were covering the right bases, or if there are aspects of screening and referral that these platforms just completely missed, that the health sector folks were finding to cause real limitations in their functionality.
Yeah, that's a good question. I would say that, we thought that the screening functionality was really going to be essential. And coming into this, we didn't find that to be as true as we'd originally anticipated. On the healthcare organizations, a lot of them had already made some progress towards doing some screening. So they had the screening in their EHR. And so they wanted to, while it was nice that the screening was in the platform, it didn't come out as the main reason why organizations were adopting. And that being said, these were really early adopters. And so those that did want the screening, that was, and the vendors were building it in as they were negotiating with the healthcare organizations. And so early adopters were able to shape the platform pretty powerfully in terms of the way that the screening was carried out.
Terrific. Thank you so much. Dora, a big topic of conversation as we're doing these transformations is sustainability. And the hope, of course, is that these accountable communities and other alternative models will generate savings that then can be used to pay for the infrastructure. But it doesn't always work out that way, and it may take longer than our hopes. I wondered if you could reflect on the range of funding sources that you described, and what their expectations are around sustainability or longevity of their commitments?
That's a hard question. I mean, so certainly I think if you look at the foundation grants or even some of the program grants through HHS, for example, they are at the outset very time limited. They're a 3-year window, a 5-year window. They want to get in and they want to get out. So you really have to think of those as seed funding or pilot funding. And so what we're finding for a number of the ACHs, the Accountable Communities for Health that we're working with, even at the halfway point of the grant, they're starting to think about, oh, what are we going to do when this grant ends? Because we're already at this point, we've establishing these amazing partnerships and the trust and the meaningful relationships, and who's going to support these functions? Who's going to, particularly when you think of some of the less resource partners, the social service organizations, for example. And so that, I think, is what's driving some of these newer models, whether the CDFIs, the community development financial institutions, they have a much longer payback range. Instead of maybe a 2 to 3 year window, maybe they're the 7 to 10 year window. Or if you think through some of these Medicaid state plans, for example, then that there's not, unlike 1115 waivers, which have to be renewed in 5 years, the state plan, I mean, that can have a much longer time horizon. So, and then there's other mechanisms that we touch on the paper. It wasn't part of our formal analysis, but when you think about wellness funds is another prime example where those are community-based local financing initiatives where you might have the local hospital, health system, you might have the state, the local government, local foundations putting in funding, and again, those tend to have a longer time frame. And even though these are newer mechanisms, we're starting to see that they're starting to sprout up at different parts of the country. So I think there is a very pragmatic understanding that we have to think longer term. But I would still say that the answers are still being explored. There's not a lot of certainty where ACHs should be turning to, although full recognition this has to be a top priority.
Yeah, so my follow-up may seem very similar, and I don't want to push you farther than we can go, given that these are under development. We're at a learning phase. But I am curious about the ability of some of these funders to enter into innovative models as opposed to grants and the like of shared savings, to sort of enter as a full-on partner, if you will, in the enterprise and say, you know, we're going to put some risk in this, but we want some of the reward, as opposed to, again, a foundation saying, here's a grant, you know, we'll renew it if things are going well, and if you can become self-sustaining, you won't need it. Just wonder what the capacity is out there for innovative funding models, particularly in given the time horizon that we're looking at.
I think the capacity, it's all across the board. I mean, we're seeing, it's pretty interesting in some states where at the state level, they're forcing ACH partnerships, and some have described it as almost like shotgun marriages. You health system, you MCO, managed care organization, you will work with these ACH models or similar type structures together to address social determinants of health or health-related social needs. So we're seeing that in those cases, that does actually help to rethink, promote these longer-term partnerships. And then others, you see other ACHs that are longer standing. They have been doing this for a longer term. Many of these partnerships, because they've been working so long together, they're able to think more creatively. They have a stronger resource base, and I would say perhaps like the Communities Care Coalition in Massachusetts that has really tackled substance abuse among teens. I mean, they have been working together since 2002, and so 18 years later, they have the foundation to take on some of these more riskier, perhaps, or more difficult types of arrangements. They have the bandwidth to explore. Whereas that's not true for these newer ACHs, where they're really just still trying to develop the partnerships and figure out what are the different sectors that want to engage. And so it really depends on where you sit, what your local state context and in terms of the funding, all of that. But it also depends on how long you've been working together. And not to belabor it, but some of these ACHs, I mean, they have benefited from communities put in prevention in the work dollars, community transformation grant dollars. They have had funding from the state innovation model. So they are building upon their historical successes and can continue moving forward. Whereas that's simply, obviously not true for some of the newer models.
Thank you. That's really interesting. Shauna, I was struck by many elements, but the one that popped out, and it's on your slides, is this notion that even as many in the health sector are looking at these forms of integration as a way to help them move away from fee-for-service, for those on the social services side of the ledger, they saw this as an opportunity to move toward fee-for-service. And that's, we could talk all day about what lessons could be drawn from that. But I guess I want to ask a fairly narrow question, and if you want to take it broader, feel free. Is it really that they want fee-for-service, as in the incentives of volume that are created and all the billing and all of those things that so many in healthcare are moving away from? Or is it really just that it's more money, that these are organizations that are resource strapped? They've been, as you note, reliant on grants and often very small revenue streams, and this is a chance for more. So I guess fundamentally my question is, are they looking for more money in general, or is it specifically fee-for-service relative to just a larger grant? Can you help me with that?
Yeah, I think that's a great question, and I think it might be a both and. I think this is one really fascinating finding from this work that points to the way that some of the ways that we use language in the health services space that maybe mean something completely different in other sectors, and are opportunities for us to really work on building shared language so that we're sure that when someone on the health services side says fee-for-service, that we're communicating in a way that we know everyone understands what that means, and that we're all on the same page. I think to your other aspect of the question, I think this speaks to the difficulty of trying to scale programs when you are fundamentally tied to contributed revenue and you're tied to philanthropic grants. And I think that was, it was a challenge for these organizations last summer when I was out doing interviews with them. I can imagine that it is probably that much more difficult now given the COVID-19 situation that we're seeing. There's not a lot of elasticity there to be able to scale up these services and these programs across the board, but especially in times of crisis or when we might see expanded need in the community. So I think it's a both and. I think in the short term, though, even just having these kinds of initiatives that can generate population level data and give us a better sense for what the needs are and be able to sort of pinpoint and make more data-driven decisions is something that seems like a really strong value proposition for all of the organizations that I spoke with. And so I think that's it's necessary, but it's not sufficient. I think if we can get to a place where we have a better understanding of what the needs are and what the scale of those needs are, then we can look at opportunities to use things like fee-for-service contracts and also things like health-related services payments to try to more concretely match the supply and demand in the system.
I was also struck by this image of these very highly resourced health systems going out to often very under-resourced social services organizations with teams of lawyers and electronic health records and maybe some of the products that Yuri described, and we need you to use these so that we can close the loop, and sort of overwhelming these much smaller organizations. You mentioned the challenge of bearing the upfront costs of doing those negotiations before any revenue comes in. I wonder if, based on your work, you could reflect at all on what kinds of support might be helpful for the social services providers and agencies so that we can get over that sort of upfront hurdle and then put more of the effort into the actual integration?
Yeah, that's a great question. I think one really obvious thing that emerged from the conversations was just the challenge of social services agencies trying to meaningfully respond to these requests from health systems when there may be multiple platforms being developed in a community and a single organization that is being asked to participate in multiple initiatives that maybe are using slightly different platforms but collecting similar data. And I think this is also an issue where it's helpful to sort of zoom out and think beyond just what's happening within health services right now, and recognize that there are a lot of different types of screening initiatives that are happening for a lot of different reasons, whether it's education or early childhood initiatives. And many of these social services organizations are being asked to participate in a variety of collective impact models, including the ones that they are being approached to participate in from health systems. So I think knowing that is helpful and is a useful piece of information to have when entering into those conversations, but also looking for ways that we can try to streamline and perhaps standardize data collection across some of these efforts could be really helpful for minimizing some of that burden.
Great. Well, thank you, Shauna, but thank you to all of you. As I said at the outset, we took the term infrastructure fairly broadly as we were looking at putting you all together into a panel. But I think if one thing comes clear through the presentations all of you have given, it's that true integration of social services and health is a multi-layered endeavor. It requires a significant infrastructure, financial, technological alignment of interests, overcoming of lots of institutional barriers and data privacy and the like. And so those who are looking at the value of this, and there's tremendous evidence for the value, also need to be realistic about the infrastructure and the investments necessary to carry it off. With that, I thank you very much for your papers, and thank you for the time for a interesting and conversation. We received some really terrific questions from the audience that I'm going to run through, and I'm going to ask each of our panelists individually a few questions and then a couple of overarching toward the end. But let me go back to Emily. We got a question in. Someone commented that the National Association of Counties has developed a standard data dictionary. Someone else asked whether other states have tried to do this. I wonder if you thought about the relative merits of doing the data matching at the state level versus the county level in terms of the complexity, and also whether, as you were going about this, you came across any other states that you were able to learn from.
Yeah, great question. So when we were thinking about kind of doing this work either at the county or the state level, one thing that we thought about is what, in a state the size of California, what types of data needs one has at the state level when you're thinking about administering these large-scale health and human service programs, and how those are different than the needs locally when you're thinking about actually delivering those services. And so the way that we thought about this was that health and human services, largely at the state, has a need for integrated data so that it can kind of effectively and efficiently and equitably administer these programs, and that they didn't necessarily have a need for real-time data because they're not interacting with clients. And so we started there. I do think that a lot of really innovative local efforts are underway in California and other states at the county level, which incorporate both health and human services as well as kind of nonprofit contract data and whatnot. So I think there are some great examples. To your second question around other states that are doing this, I know of a number of states that have initiatives that are internal to their health and human services agency, and I also know of states that are partnering to some extent with universities. I do think that what California has built is somewhat unique in the sense that what they are creating is a data asset management platform. So beyond kind of the linkage of data, they're really trying to think about how they make that data available not only to their internal analysts, but external researchers. And if anything, I would say that that model is based off of some of the models we see internationally. For example, Statistics Denmark, where they've really kind of brought together lots of data and then come up with a very secure vehicle for making that information available to both internal and external partners.
Great, thank you. Yuri, we got to questions about the platform. Partly, one question is how this differs from, or whether the platforms are basically built on the same chassis as 211 programs and things like that. But also a question about, that I'm going to expand a little from what the listener wrote in, the reach of the services into very underserved communities, non-English speaking communities, sort of how much are these platforms able to really go into the community level? You mentioned earlier about some of them harvesting very large data sets, others being linkages. So just wonder if you could address those two questions.
Yeah, so the first question about 211s, I would say it depends because there's not really a singular 211s. It really depends on the individual local 211s on what kind of technology infrastructure they use. And so in essence, though, it does help to think of at least the resource directory side of these platforms as being a little bit similar to the kinds of listings that you can find in 211. The second question about the reach of the platforms into minority or underserved communities, it depends on who the customer is. So has this platform been adopted by a community health center serving that area? So there's no blanket answer for all of the platforms. I will say that, I talked a little bit about cost in my presentation. Some of these platforms are prohibitively expensive for small free clinics or community health centers. So I think that may limit the access for those communities.
Great, thank you. Dora, one person asked if you could just be a little clearer about what braided and blended mean. So I'll ask you to do that quickly, but then turn to another question, which is you listed a large number of potential funding sources and agencies. And the questioner wondered, do those agencies require any sort of on-the-ground integration, any sort of cross-departmental work, or are the funding sources just as siloed as what it is we're trying to break down on the service delivery side?
Sure. So I'll start with the definition of braiding and blending, I'm not aware of an official definition, if you will. For purposes of our project, and I think it's generally accepted, when we talk about blending, that's generally more formally combining or pooling the funds together for a common purpose. They still may have their individual reporting requirements, but the funds are able to be pooled and combined. And that contrasts to braiding, in which case you could coordinate the grants, but you cannot pool the fund, you cannot combine the funds. Each of the grants have to be used for the specific purpose, the specific population for which it was intended. And that turned out to be the case for most of the public grants that we analyze, whether from CDC or HRSA or SAMHSA, even if it was for, let's say, an anti-smoking campaign, if you will, you still have to use the CDC grant for its purpose, the HRSA grants for its intended population, and so forth. In terms of your question, are we seeing a lot of silos within these grants, I think, or how are we trying to integrate? I would say with a few exceptions at the federal level, still there is a lot of individual work. I could think of perhaps through the workforce grants that Department of Labor mentioned in the paper, the workforce development boards, I think there are requirements that they coordinate with TANF and SNAP. But even still, I'd be hesitant to say whether it's required or strongly encouraged. So at the federal level, we still see a lot of silos. But at the state level and local level, I think that you are seeing, again, I think as I referred to earlier, some shotgun marriages or really strong encouragements to work together. I would note for the integrated care for kids model that CMMI just launched, I think they do require state Medicaid agencies to participate as part of the grant, but even still, that's still kind of within the same sectors, so not quite as you described it, housing, working with food or health. So I think that as this type of model continues to move forward, that's an interesting question for policymakers. How can we encourage more of that type of work? I would be remiss if I didn't say that for this paper, we have, since we finished the paper, we have published an issue brief with more examples of different communities that are trying to use these different financing mechanisms. There are also case reports that, again, are providing examples in the field, and all of this can be found at accountablehealth.gwu.edu. So for those looking for more specific examples, I think that's a great resource.
Great, thank you. Shauna, just to follow up, not to go too deep into the terminology that we started discussing toward the end, but I did get a question about the relationship between population payments or value-based payments and fee-for-service reimbursement. And I don't know how far your work went into this, but if I'm reading the question right, it's really about whether these types of payment are passing through to the community organizations. Sort of, is it shared risk in the sense that if we as the health system that's getting a value-based payment are able to show improvement, we will share in the benefit with the community? Or is it really we're purchasing services from you piece by piece? Let's not get caught up in the fee-for-service language, but we're doing that with the goal of getting payment for population health outcomes. Did you get to that level of nuance?
We didn't get to that level of nuance in this research, and I think it is something that really warrants a lot of further exploration and kind of communication, or trying to unpack some of the deeper complexities around what this means for a social services leader to try to integrate and do that in a sustainable way. I think there are a couple of ways that, or a couple of sort of pathways that are starting to emerge for what this could look like. And I think it probably depends a lot on the local context and the state policy frameworks that are in place in any given community. But here in Oregon, for example, we've leveraged our 1115 Medicaid demonstration waiver in order to create or authorize our managed care organizations to be able to make what are called health-related services payments. And so this is a fairly new policy innovation that's happening in Oregon. Things are kind of just getting started this year. But the hope there is that our managed care organizations will begin to move toward both community level investments and also individual level investments in services that address social needs. So I think that that's one example of how this might look. I think the intersection with value-based payments is also one opportunity where I think that this could start to become more actionable for people. So I think as we were talking about in areas where states are trying to move providers into more capitated payments, that does start to create opportunities for individual provider organizations to have flexibility to enter into partnerships with local CBOs in ways that might help them to create more of a alignment between the volume of referrals that are being created for unmet social needs and then services that are actually needed to respond to those needs. So I think we have options at multiple levels, and all of those options are worth exploring at this point. I think we're in very early days with a lot of this work, and so a lot of that those innovations haven't really been tested yet. And it's, I think, an open question of which one of those approaches is going to be the right one moving forward. I think one of the things that our research did kind of point to is that kind of going back to the issue of risk perception, there are different risk perceptions when an organization, when a social services organization is being asked to enter into a collective impact initiative where there might be a lot of partners and there might be a lot of sort of complex accountabilities across multiple people or multiple organizations. The risk perceptions for those types of partnerships are different than the way an organization might perceive risk if they're just sort of entering into a partnership or a contract with a single provider organization. So I think we need to be exploring all of those things, and we need to be considering what incentives look like in those various models.
Okay, I'm going to ask one last question of all of you, and it's a slightly long question, so it's okay if you have slightly long answers, but I think it's important to hear from all of you. When I think about the breadth of topics you all covered in our overarching theme of infrastructure, the question is, what are we trying to do? It's not just moving dollars around. It's not just changing payment methods. What are the underlying goals? And these arise from some of the questions that we got during this session. One is to identify new partners. If we're just sort of solidifying relationships that already exist, then we're missing the opportunity to bring in new partners. One is to identify unmet need, to say, in order to achieve better health, better well-being, these are the places we need to move resources that are not being met. And the commonly discussed goal of moving funding upstream, more to prevention, more to avoiding problems and waiting. So I realize that each of the work that each of you did, very different, but I wonder if each of you could reflect on the degree to which what you were a part of or what you were studying gives you a sense of whether or not we are finding new partners, identifying unmet needs and putting resources there, and moving our funding upstream, or any combination of those. And since it's to all of you, you get to choose who goes first. So whoever wants to start, take it away.
This is Emily. I'll go ahead and take the first pass at this. So what I would say, broadly defined for California, is that the focus from start to finish has been about how do we improve outcomes for all Californians. And the historical methods we've had for assembling and working with our administrative records and data when thinking about how we design programs and how we make investments has been, again, very, very focused on just, we have this one funding stream, we have this one traditional method for administering services, and we really haven't, I think, thought about it from the perspective of the consumer and the human being and the client or the patient. And so I think with that in mind, even though everyone would love to see us jumping immediately to kind of integrated data that can be used for real-time purposes, which I get, I think that this is a huge step forward, because for the first time, everyone within HHS is able to kind of start to reorient from thinking about my clients or my patients and those people over there to thinking collectively about, these are our children, these are our families, these are our shared clients. And I think that that really has the potential to promote some important outside of the box thinking in terms of how we more strategically target some of our services upstream and through a lens of prevention and early intervention. I also think that it has really important kind of implications for how we hold ourselves accountable for outcomes that may be inherently cross-system outcomes. And so I certainly would not say that in any way we have yet realized the vision, the kind of the potential of what has been built, but I think it's a really, really critical first step. And if I'm to give one example where just having some integrated data, I think, has already kind of lent itself to some new thinking. One of the first linkages that was done, and it was kind of an ad hoc linkage before we had the agreements in place to do a record reconciliation or to return data to the state. But it actually involved looking at how many young women who were placed in out-of-home foster care were also parenting or had recently given birth. And that was a really kind of critical question for the state, as foster care was extended from an emancipation date of age 18 to an age of 21. And being able to link up child welfare records, link up birth records, develop that data, it really kind of brought people to the table where there could be conversations around how do we support these young parents? What kind of subsidized childcare options do we need? How do we think about how many more of our young adults who are in foster care at age 18 and perhaps haven't given birth, but will be giving birth at 19, 20, or 21? How do we start to kind of adopt a two-generational lens to the services that we're delivering? So I offer that as just one example where I do think that that we will see that these data promote more of those kind of opportunities for cross-system collaboration. Thank you.
So I'm happy to go next. I think at its core, the Accountable Communities for Health model is about bringing together these diverse partners and strange bedfellows, if you will. We recently held a convening that was focusing on the health equity impact of ACHs, and I was struck that one large hospital health system said one of their outcomes measures were third grade reading levels is one example. And even though we had started off saying ACHs span partnerships of health, social services, and public health, one of their prime metrics was education. And if you think of another, I could think of another ACH in Massachusetts, they are very much working with law enforcement. And so that is an additional sector. Or if I could think of another, as another example, I think through partnerships by a foundation in California, they're looking at levels of incarceration. And so it's not just the core social services, if you will, but it's really going beyond that to other partners that are very critically important partners at the community level in terms of promoting health in its purest and most holistic fashion. And so I think that the ACH partnership is already demonstrating its potential to move beyond the usual partners, if you will, and to bring in the others. And certainly the business sector would be another prime example of some of the CDFIs as another thought. And I think that that is, in fact, is what was driving this project, focusing on financing the infrastructure. It's not the services. We can find money for that. They're already being supported in so many ways. But how do you engage these partners? How do you develop this common vision? How do you drive this agenda when you have well-resourced and long experienced partners with these newer partners who haven't really thought about their work in the health context? And that's the exciting part of this work. I think that's where the potential is. And that is, in fact, the core reason why we are helping to identify sources of funding to keep this going in the long term.
I can go next. So I'm going to take the last one first in terms of the funding. What was interesting when we did our review was that we didn't see any functionalities inside these platforms specifically set up for example, paying social service organizations for the services they provided. And so this is a hunch. It's probably coming down the line. I wonder if, Shauna mentioned that several of these platforms are being used by different organizations in the same geographic area. They're also being used in different ways. So I know that one of these platforms, if not being used directly for an ACH, is being used in the same area as an ACH for a different and interacting initiative. And so it's not necessary perhaps for these platforms to meet, to be able to build that in, but there should be some interoperability with systems that would allow for the reimbursement or being able to contract with healthcare organizations or others. The new partners, we did see this. There is a lot of potential for these platforms once they're implemented in an area to kind of pick up steam and for the networks to grow and bring on new partners, specifically to meet the unmet needs of their patients or clients. And so I think that is an area of great potential for these products. However, I'm concerned that we might be putting a little bit too much, it might be giving a little bit over too much power to for-profit companies. This is the purview of our article, but taking a step back, we're talking about some really basic infrastructure. And do we want that infrastructure? Where do we want the locus of power for that infrastructure to be? And so I think kind of going forward, this is one of the big questions that we have to grapple with.
Thank you. This might be a little bit more esoteric of an answer than you were intending when you asked this question, but I've been sort of reflecting on the way that this panel was framed, that we sort of established this as a conversation about infrastructure, and we've spent a lot of time talking about funding models, and we've spent a lot of time talking about technology and data infrastructure. And I think the sort of elephant in the room is the people behind those systems who have to be on board to make all of this happen and make all of it go. And so I think if I have a sort of overarching thought or reflection on all of these conversations today, it's that the people in these systems are part of the infrastructure, and we really need to be thinking about how we help people to do the things that they already want to do. I think it was clear to me in the conversations we had for our research that people are very on board with the idea that we need more action and we need systems change around some of these issues, and at the same time are sometimes just trapped within systems that don't allow them to make the kinds of operational changes that they would like to make. So I think listening to people, really going to the front lines and understanding what some of the operational challenges are that come up for people when they try to implement some of these changes is really important. And I think we should assume that people have really good intentions and that there is a lot of momentum and desire for change, and that we need the policies to support that.
Well, I don't think that was too esoteric at all. I think it's a great way to close this conversation. We did use the term infrastructure. It does have a sort of abstract sense to it, but the systems are built around people and do or don't serve their needs. So I appreciate that as a good closing thought. I want to thank our audience for submitting some terrific questions. Dora, Emily, Yuri, Shauna, thank you for doing this with us twice, once to record and once live to take some more questions, and of course for your contributions to the journal. I hope people will read the articles beyond watching this and take a look at the entire April 2020 issue that looks at other dimensions. And with that, and thanks to the Kresge Foundation for making this possible, we are adjourned.
Thank you.